Hi everyone, a very good evening to all dear students. Welcome to this booster session. Let me know in the chat box if I am audible and visible to all of you. I hope all of you are doing really well. A very good evening, hi, a very good evening everyone. And we'll be starting the 100 one-liners of psychiatry. Of course, it will not be just one-liners, we'll discuss some important concepts also in today's session. Now, as we have the NEET, PG, FMGE and NICT exam in the mid-year, so this session will be useful for all the students who are preparing for all these exams, right? So again, a very good evening. Now, also what we have done is, I have picked up some important topics for today's session. Now, many of us would be in the beginning of our preparation. We might have started, or some of you have already started the preparation. So what I've done is, since we are meeting in the beginning of your preparation, we'll discuss some important topics. So I've picked up some important topics which include the basics. We'll discuss some important basic concepts of psychiatry. We'll talk about some important disorders, including neurocognitive disorders, that is organic mental disorders. We'll discuss schizophrenia. We'll talk about mood disorders, depression, bipolar disorder, and very important again, we'll discuss substance use disorders. So what I've done is, we have picked up these important topics. Again, when we'll meet in LRR there, we will discuss all the other topics as well. But since we are in the beginning of the preparation, we'll discuss some important concepts. So what we're going to do is, we are going to discuss all the important previous year topics from the list of topics I've discussed, and also I'll discuss all the important recently asked previous year questions as well. We'll not mug up things, we'll try to understand concepts, and I'll bring some cases in the class so that we understand those concepts fully. In fact, I'll give you lots of tricks and mnemonics also, so that you can remember these concepts as well. In fact, Shakespeare says that what's there in the name. I always say that names in psychiatry are very important. You remember the name and I'll help you understand and remember the concept. Now also we'll talk about some latest updates. We'll discuss certain updates, and again, very important part of the session will be FQs. FQs, I say the future questions. Some new questions also we'll discuss which have potential to come in the exams. And also I'll integrate certain important aspects of psychopharmacology. Very important, you'll see a lot of questions from psychopharmacology are asked these days. So I'll also discuss wherever relevant some important drugs as well. Yes, so let's start with the session. So we'll start with the concept. We'll build on the concepts, and then we'll make our concepts stronger in this session. Again, you will see that many of these topics are again and again asked. So let us begin. So I think everything is perfect to begin today's session. So let's start with some one-liners. Since we are beginning with one-liners, the term psychiatry, it is derived from two Greek words. Psyche means mind, iatry means healing or cure. Can you tell me who coined the term? This term psychiatry was coined by German physician with the name Johann Christian Riehl. So remember, the term psychiatry was coined by Johann Christian Riehl. Now when a patient comes to us, we will do general physical examination, we'll do systemic examination. But in psychiatry, what is the assessment? Psychiatric assessment of a patient known as, very good, yes. So that is known as mental status examination, that is MSE. Again, old question, what is the psychiatric assessment of a patient known as? As the name suggests, we are examining the mental status of the person. Very good, it is MSE, that is mental status examination. The first and very important topic which we'll start with is the MSE. Now when we'll discuss MSE, that is mental status examination, you can understand in a way, we are going to discuss some important signs and symptoms of psychiatry. So let's begin with the MSE. So in the MSE, let's talk about the first important concept. Now tell me, a patient has come and we are observing his expression of emotions. So we are trying to observe, some of the emotions which are expressed on his face, in his body language. Can you tell me what is that known as? Very good, that is known as affect. So the first important aspect of MSE which we are going to discuss is affect. So in fact, let's try to understand the difference between mood and affect. Now let's try to understand. Both these terms are related with emotions. Now mood is basically persistent and pervasive emotions which the patient is feeling from within. So mood is something which you feel from within. For example, if I have to ask your mood, very important to remember, I will ask like this. How has been your mood since the past few days or weeks or months? So I'm trying to ask, what are you feeling from within? So that is what is mood. It's a persistent and pervasive emotional state. Please remember, mood is something which is long term. Can you appreciate? I didn't ask how is your mood today. I asked how has been your moods in the past few days, weeks or months. That is how we define mood. Then what is affect? Affect is that our emotions basically are expressed on our face, in our body language. Don't say it's bad, again it will let up, after the session we'll try to let up it. So affect is when our emotions, they're expressed on our face, in our body language. Very often we see sometimes our friends, our family members have not said anything, but just by looking at them we are able to understand, what happened, why you're appearing so sad, why don't you take something. So this is what is affect. Now let's discuss a very important point, some abnormalities of affect. Again, this is very important. Now there are certain concepts which I'll put a hashtag. Nowadays anything which is trending you put a hashtag. So there are certain hashtags also I'll keep so that you understand that when you're revising, please do revise these points. So let's discuss some abnormalities of affect. Suppose family members come to us and say that any happy event occurs at home or any sad event occurs at home, the patient shows no changes in his emotion. There is no change in the affect. Are you able to appreciate what we are trying to say? So family member says, sir, there is a very happy moment at home, there is very sad moment at home, but see, the patient is looking like this. There is no change in the expression of emotion. Can you tell me what is this? Very good. This is known as flat affect or also known as blunt affect. Very good. So are you able to appreciate this as an abnormality of affect? Now tell me one important condition where you may find this. Where would you find flat affect or blunting of affect? It is seen in which condition? Yes, it is seen in schizophrenia. In fact, this was a question asked in the January 2025 FMGE exam. We'll also discuss the previous year questions also. So please remember, this is what is known as flat affect. Is it clear to everyone? Please remember, in depression, the patient will show features of sadness. Here I am saying that any happy event occurs, any sad event occurs at home, there is no change in the emotion. That is what is, as if, again I always say, remember it by the name. When you do a ECG, you will see such waves. But what is the finding when a person is dead? The ECG shows flat line. So always remember, just remember the name, flat affect, as if the emotions are dead. This is what is known as flat affect. So please remember this, understand the concept, remember the terms, and you will understand the concept. Now let's discuss one more abnormality, just opposite of this. Here we were saying that we are giving patient some stimulus, happy moments, sad moments, but there is no change in the emotion. Now suppose a patient comes to us and we are talking to the patient, I have not cracked any joke, the patient has not cracked any joke, nothing funny has happened around. But the patient starts laughing, then within few seconds he starts crying, then again starts laughing. This rapid and abrupt changes in emotion, can you appreciate? Here I can draw it like this. So without any stimulus, there is rapid abrupt changes of emotions. What is this known as? Can anybody tell me? This is known as labile affect. Lability, very good. This is labile affect. Now, can you tell me some important conditions where you may find this? Any important condition where you may find this labile affect? Okay, I'll also discuss incongruent and inappropriate affect. These are also two other abnormalities, but let's see first labile affect. Can you tell me? Yes. One is mania. Very good. You call it mania or bipolar disorder. I'll take both the answers. One important condition you can also remember, organic mental disorder, also now known as neurocognitive disorder. So this is again very important. I hope these two important points are clear to everyone. Flat, just see the name flat, as if the emotions are dead. There are no changes in emotion. Labile is something which is changing. So there is rapid and abrupt changes of emotion. Okay, let's discuss two more abnormalities. Since we are discussing abnormalities, let's also take up two more abnormalities. I hope these two are clear to everyone. Right. Now third is, see this, third is inappropriate affect. Inappropriate affect. And another one we'll discuss, that is incongruent affect. So let's discuss all these terms here itself. Because when you will be solving questions, when you'll see the QBank, PrepLadder, you'll see these terms, you should know about these terms. So see this, inappropriate affect means that the affect is not appropriate to what? Here it is not. So you can remember it like this, that the affect is not matching with the situation. Very good. It is not matching with the situation. Suppose a person goes to the funeral, somebody has died in the family, everybody is very sad. The person goes to the funeral, he sees the dead body and starts laughing. So can you appreciate here, the affect is not appropriate with the situation. So this is inappropriate affect. Then what is incongruent affect? Congruent means to match. Incongruent means here affect is not matching with what? So here remember, affect is not matching. Can anybody tell me? Incongruent affect, where affect is not matching with what? It is not matching with the mood, or you can say it is not matching with the thoughts of the person. Very good. Now see this. So suppose we ask the patient, how is your mood? See what the patient replies. See how he is replying. The patient says, sir, my mood is very sad. My mood is very sad. Now please see what is happening here. What is the patient saying? How is his mood? The patient is saying, sir, my mood is very sad. But can you appreciate what was the affect? What was the affect of the patient? He was appearing very happy. Can you appreciate? Mood and affect, they are poles apart. They are not matching. So this is incongruency or incongruent affect. Again, remember, these terms again can be seen in conditions again like schizophrenia. I hope all these 4 terms are clear to everyone. You will see a lot of such questions being asked these days. Okay. So I hope the concept is clear to everyone. Just see the name, remember the name, and you will understand the concept. So this was about affect. Now let's come to the next very important topic. In fact, this I say the VVIP topic, that is thought. Now we are trying to understand, we are trying to assess the abnormalities of the thinking. Now first we'll talk about delusion. Delusion, I'm sure all of us have heard about. Yes, so I'm asking you, delusion is an abnormality of which domain of thought? Is it flow? Is it content? Is it form? Or is it possession? So we'll discuss the abnormality of thought under these 4 domains. Tell me, what is the right answer? Very good. I'm very happy all of you are marking correctly. It is, yes, it is abnormality of content of thought. So some, again a previous year question was delusion is an abnormality of, the answer was it is an abnormality of thought. And under thought, if they ask you, it's an abnormality of content of thought. Now let's try to understand the definition of delusion with this question. So again, I'll discuss some newer questions also, so that you have an idea how newer questions may be framed. Okay. Again, please remember, nowadays seeing the trend, so many years we have been seeing that they are not repeating the questions. So they are giving you newer questions. But yes, of course, the topic is getting repeated. Now tell me, which of the following is not true about delusion? It's an abnormality of thought. Yes, we discussed. Delusion is a false, fixed, firm idea or belief which is held with extraordinary conviction. So it's a belief, it's an idea which is false, but it is fixed and firm in the mind of the patient. Whatever evidence I'm trying to tell the patient, give the patient, he is not getting convinced. Very important. Tell me, is it explained by social and cultural background of the individual? No. In fact, these are unexplained. These are unexplained by the social cultural background of the person. So delusion you are not able to explain with the social cultural background of the patient. Can anybody tell me what is the term used when we say that a belief which may be false, which may be fixed, but it is explained by social cultural background of the patient? What do we call that term as? Can anybody tell me what is that known as? Remember, that is known as superstition. There are certain certain societies, certain cultures have certain beliefs. For example, let us say a person believe, or a society, in a society people believe that if a black cat crosses your way, something bad will happen. Kali billi ne rasta kaata, kuch apshagun ho jayega. Sometimes people believe it so firmly that they may wait for 15 minutes, half an hour till somebody else crosses by. So it also appears to be a firm, fixed, false belief held with extraordinary conviction, but we can explain it with the social cultural background of the patient. So that is superstition. So that is yes. So that helps you differentiate delusion from superstition. Now let's talk about, so again, as we were discussing, delusion is an abnormality of content of thought. Let's discuss some important types of delusion. Again, you will see a lot of questions being asked on the types. Many times they will give you a clinical situation and they will ask you to identify what delusion is, or you are asked to identify the symptom and then make a diagnosis. Now please remember, delusion we say it is a psychotic symptom, very important. So delusion we say It's a psychotic symptom. It can be seen in psychotic disorders. In fact, it can occur in various other conditions also. We'll discuss. So let's try to understand the types of delusion. So what is this delusion? The person thinks that somebody wants to kill me. You know, my neighbor wants to kill me, somebody wants to harm me. Yes, that is known as delusion of persecution. Very good. Now please remember, persecution, delusion of persecution not necessarily always means to kill, harm in any way. A college student believes that the college principal along with the teachers want to fail him in the exam, want to expel him from the college. So again, this is also a type of delusion of persecution. Which is the most common delusion in psychiatry? Which is the most common delusion in psychiatric disorder? It is the most common delusion. Now, another clinical situation, patient believes that people are talking about him. So, patient thinks that other people, he cannot hear but he thinks that they are talking about me. Or the patient says that somebody is spying on me, there are hidden cameras, somebody is spying on me. What is this delusion known as? What is this delusion known as? Can anybody tell me? So can you appreciate, you know, again just see the name. Here the patient thinks that everything is occurring in reference to him, isn't it? So this is delusion of reference. Very good. A patient is watching television and he is watching news and he thinks that the news anchor is, you know, giving some hidden messages, is, you know, giving him some clues. So what is this again? You know, he's thinking that things occurring around him are in reference to him. This is delusion of reference. So please remember, this is delusion of reference. So these are the two delusions we have discussed. Let's now discuss two more delusions. One is when the patient is making false big claims. Patient says, I am the king of the world. Patient says, I have vast knowledge. Yesterday Donald Trump became the president of USA. It was because of me. I made him the president. You know, such false big claims the patient may make. So what is this? What is this delusion known as? Can anybody tell me? This is known as delusion of grandiosity. Very good. This is delusion of grandiosity. You know, we discussed, it's a, you know, delusion is a psychotic symptom, can be seen in psychotic disorders like schizophrenia. Can anybody tell me any mood disorder in which this may also be seen? Can you tell me where else you can see this delusion of grandiosity? We'll talk about that when we'll discuss mood disorder. You know, sometimes it can also be seen in mania. Very good. Sometimes it may also be seen in mania. So here the patient is making false big claims. Patient may, you know, think that he has supernatural powers, you know, he has vast knowledge, he has huge wealth, or he knows famous people. Such big false claims patient makes. So this is delusion of grandiosity. Now just opposite of this, just remember, in another delusion, patient is denying existence of the self. Patient says, sir, I am dead from inside. I don't have a brain. I don't have an intestine. I'm just a plank of card. Or the family members are dead. Patient may claim all my family members are dead. You know, the brother is standing next to him and saying, what are you saying? But he says, no, sir, all are dead. All are just plank of card. Or this world is a dead world. Can you tell me what is this delusion of? Very good. This is delusion of nihilism or delusion of negation. Very good. Now, one important syndrome which you can remember, in fact, you know, this has been asked previously, a very old question, a one-liner question, and also in the NICT also this question was asked. So first let's understand Cotard syndrome. What is Cotard syndrome? So can you appreciate again here in delusion of nihilism, patient has become extremely negative. So yes, it can also be seen in, you know, disorders like depression. So Cotard syndrome is a term. Very good. Very good. Cotard syndrome is a term, a patient with depression developing delusion of nihilism. Then we call it as Cotard syndrome. So Cotard syndrome, patient is having delusion of nihilism. Now this question which was asked in NICT, a very interesting question was asked. They had told that the patient is having depression and the patient says that I am dead, I don't have a brain, what is the point of eating? So there they had shown that the patient had delusion of nihilism and the question was asked. Always, you know, when I will be discussing these one-liners, these topics, I'll also discuss, you know, how they are framing questions. So this was the question, a patient with depression developing delusion of nihilism. The question was, which delusion is seen in the patient? Options were, one was delusion of nihilism and another option was Cotard syndrome. So can you tell me what will be the answer, A or B? Will you choose delusion of nihilism or will you choose Cotard syndrome? What will you choose in this situation? Okay. Yes, even other delusions can be seen in depression, not just delusion of nihilism. Okay, other delusions, delusion of persecution, reference, these can be seen in depression. So what will you choose? Will you choose delusion of nihilism or will you choose Cotard syndrome? Again, always read the last line very carefully what they were asking. They were asking which delusion is seen. So there the answer was, of course, again, I'm sure all of us would remember the concept, but sometimes this is the trick. So always read the last line very carefully. The question was which delusion is seen. So answer there was, it was delusion of nihilism. Is it clear to everyone? So this is grandiosity, delusion of grandiosity, and this is delusion of nihilism. Now let's discuss two more delusions. They have different names as well. So a patient claims that someone else is in love with the patient. So patient says that that other person is mad about me. For example, let us say a 25-year-old female claims that Salman Khan is in love with her. The Big Boss show which he hosted yesterday, the winner, he claimed, he made the winner by asking me. In the movie, all his movies, he's searching for me. The movie which came, Kisi Ka Bhai Kisi Ki Jaan, in that Jaan was me. So patient is claiming that someone else, usually of a higher stature, is in love with the patient. What is this known as? Very good. This is known as T. Clermont syndrome, also known as erotomania, also known as delusion of love. Okay. So this is one delusion which we have discussed. Very good. Now another delusion that patient thinks that his partner or his spouse is having an affair. So 40-year-old male, he claims that his wife is having an extramarital affair. Everybody is trying to convince him otherwise, but he is not getting convinced. So in the question they are trying to tell you that it's a delusion. Can you tell me what is this delusion known as? Very good. This is known as Othello syndrome, also known as delusion of infidelity. Infidelity means that the partner is cheating, infidel, also known as morbid jealousy. Very good. So please be very careful when these names are asked. Sometimes these names may be used in the options. So please be very careful. Now, one more important point which you can remember. Now, so this same patient we are discussing, 40-year-old male doubting his wife having an affair. In the question they ask which substance he is consuming. Options are cannabis, cocaine, amphetamine, alcohol. So what is the answer here? Anybody? So, now they're trying to ask you that which one important substance may be commonly associated with this delusion. What is the answer here? Please remember. Okay. Yes, in other substances also it may occur, but very important substance which you need to remember may be associated with delusion of infidelity or morbid jealousy. Very important. What is that substance? Yes, in fact, that is alcohol. Very good. So please remember this, such questions may be asked. Okay. I hope this is clear to everyone. Now let's discuss another important group of delusion. In fact, let's discuss delusional misidentification syndrome. Now I hope this is clear to everyone. Now see this question. So 40-year-old male patient brought to the psychiatry clinic with an illness of 10 years, and family members report that when any happy event or sad event comes at home, he shows no changes in emotion. So this we have already identified that this is known as flat affect. The family members further say that he also doubts that his wife is not his wife but a neighbor in disguise, and doesn't get convinced even if they try to give contrary evidence. Can you appreciate here? They are again trying to tell you that patient has developed a false fixed firm idea or belief held with extraordinary conviction. First of all, you should be able to identify the phenomena. It's a delusion. Very good. It's a delusion. And what is the delusion we are seeing in the patient? Yes, it is Capgras syndrome. Very good. We'll talk about this Capgras syndrome. Very good. So let's discuss delusional misidentification syndrome. Again, I always say just remember the name, misidentification. Person is not identifying the person correctly. Now, as in this case, you can see close person here, the wife who is a close person has been replaced by a stranger. This is what the patient is claiming. So this is Capgras syndrome. Now let me give you a very simple trick to remember. See the name. You will just see the name and you will understand. See the name. So in this, just see these terms, alternating terms, CPRS, Capgras syndrome. So from the name itself, you can remember close person replaced by stranger. This is Capgras syndrome. Okay. Now, another situation, patient is claiming that a familiar person is imposing as a stranger. Here, opposite is occurring. Suppose A patient goes out in public, he is walking in a park and he meets a stranger, let's call him S1. He says to the stranger, you're looking like a stranger, but you're not a stranger, you are my wife in disguise. So here he thinks that a familiar person is imposing, is coming in front of him as stranger. This is known as Fregoli syndrome. Very good. So this is known as Fregoli syndrome. I hope all of you will be able to identify Capgras and Fregoli. You know, sometimes patient may think that the familiar person can take multiple appearances. So he may, let us say, meet another stranger, let's call S2. Again he says to this stranger, you're looking like a stranger, but you're not a stranger, you are my wife in disguise. What are you doing here? Let's go home, let's go home. So the trick to remember, again you can remember this trick. So tell me, in Capgras syndrome, C for Capgras, patient is fighting with whom? Can you appreciate in this question, the patient is fighting with the close person, isn't it? He is telling the wife, you're not my wife, you're someone else. So remember this, in Capgras syndrome, C for Capgras, C for close person, he is fighting with the close person. You know, sometimes, you know, when we are solving question in the exam, we are having so many, you know, knowledge of 19 subjects, sometimes we may get confused. So remember these tricks so that you don't get confused. While in Fregoli, if you see, in Fregoli, he is arguing with the strangers, na, that you're not stranger, you are a familiar person. So here, the person is fighting with the stranger. So remember these simple tricks so that you don't forget. This is Capgras and Fregoli syndrome. I hope these two are clear to everyone. Again, you know, previously also these questions have been asked as one-liners also. They have asked these questions clinically also. So you may be asked these questions. Now one interesting point which I want you to remember. Can anybody tell me? I'll come to that point again when we'll discuss dementia. Capgras syndrome is associated with one important dementia. Can anybody tell me which is that dementia? In fact, that question was asked in the FMGE exam. In the PYQs, you will see this question. So tell me, Capgras syndrome is associated with which dementia? Of course, it can also be seen in Alzheimer's disease. But one important dementia, if they ask, can you tell me? Okay, pig disease, good attempt, good that you are attempting. So can anybody tell me Capgras syndrome, one important dementia? If I ask you, I'll talk about that. Now, starts with L, starts with L. I'm giving you a clue, a very important topic which I'll cover. Can anybody tell me what is this dementia I'm talking about? This is very good. This is Lewy body disease. Very good. Lewy body disease, Lewy body dementia. Very good. We'll talk about this. Lewy body is a very important topic. So remember here only that Capgras syndrome, sometimes patient with Lewy body disease may present with Capgras syndrome. So remember this point. Okay. So one very important topic under thought we have covered, that is delusion. Now let's discuss the second domain. Very good. Let's discuss the second domain of thought, that is flow or stream. Now just see this. Just like water flows in a river, similarly when you sit silently you will see that the thoughts are flowing in our mind. So now we are trying to see the abnormality. Is there any abnormality of flow of these thoughts? Now a patient comes to us and he says like this. See this, what he's saying. The patient says, I am Tom, I am a con, my friend is gone, I want an iPhone, time is done, let's call Sean. Which of the following symptom is seen in the patient? Can you tell me? Can you appreciate, identify this phenomena? Can you identify this phenomena or this symptom seen in the patient? Patient is speaking things which are not making much sense, but can you see some connections? I am Tom, I am a con, my friend is gone. Yes, there is clang association. Very good. There is clang association. So here we are talking about, very good, we are talking about flight of ideas. Flight of ideas. We'll talk about this. Yes, you are seeing rhyming, you are seeing clang association. Very good. Now tell me, flight of ideas. Very good. This is clang association. Okay. Now flight of ideas, will talk about this, that the speed of the thoughts is increased. Now why I am mentioning a flight of ideas, you know, although if they would have said that the speed is increased, then I would have said flight of ideas. Sometimes they may not tell in the question, in the written question, you will not be able to identify speed until unless it's not mentioned. So we'll talk about this. First tell me one important condition where you will find flight of ideas. If I ask you one, remember it is mania. Very good. If it is asked one condition, we'll talk about this when I'll discuss the symptoms of mania. I'll give you a mnemonic. In that there is one letter F. F means flight of ideas. But again remember, it can be seen in other conditions also, such as even in schizophrenia. Even in schizophrenia, you may find flight of ideas. Even in organic mental disorders, it can be seen. But if they ask one condition, remember it is mania. Now, let's talk about some abnormalities under flow or stream of thought. Now, first we'll talk about flight of ideas. In flight of ideas, we are saying that the speed of the thoughts is increased. So the thoughts in the mind of the patient, they are coming very fast. So one thought, second, third, fourth, fifth, they are coming very fast. So the speed is increased. So when you listen to the patient is saying things very fast, and sometimes he'll say things which may not make much sense, like in the question we discussed. But when you look carefully, you will see that the thoughts, they are connected somehow. They may be connected by what is known as chance factor. For example, a patient speaks like this: my name is Virat, I like playing cricket. Cricket is a game of gentlemen. Gentleman is my friend Mukesh. Mukesh smokes cigarette. Cigarette causes cancer. Cancer is my zodiac sign. So can you appreciate here, things what he's saying may not be making much sense, but one thought is connected by other by a chance factor. ये मौसम की बारिश, ये बारिश का पानी, ये पानी की बूंदे तुझे ही तो ढूंढे, something like this. So thoughts may be connected by chance, and sometimes you will see that the thoughts may be connected by what is known as clang association, that is rhyming words. Like in that case we saw. So patient may speak like this: Ram can sing, birds have wing, I am the king, phone goes tring tring, the weather is spring, bring 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 bring. So this is clang association. So this is flight of ideas. So how to identify? Again, see this. The patient is saying so many things, not making much sense, but when you will see some connection. So this is flight of ideas. I hope this is clear to everyone. Now, let's discuss some more abnormalities. Second is, let's talk about circumstantiality. Now, so in circumstantiality, first of all, the speed is reduced. So the patient is speaking slowly. And what is happening in circumstantiality? Now, here the patient is giving unnecessary or trivial information. Patient may be saying those things which you have not asked for, unnecessary. Those details you have not asked for, but patient is still giving them. But finally he answers the question. So what we'll say, the goal is reached or not reached? The goal is reached. So this is circumstantiality. For example, if somebody has to go from A to B, rather than going straight, the person is going like this, giving unnecessary trivial information, but here he's reaching the goal. Again, in the written question, sometimes here when the speed is not mentioned, how will you identify? If you see in flight of ideas, whatever the patient is saying may not be making much sense, and there is some connection you are able to find, and we say the goal is not reached. In flight of ideas, the goal is not reached. So remember this. While in circumstantiality, I'll show a question, recently asked question in the FMGE exam. We'll discuss that question. So that is why I'm saying these are very important concepts. They may frame new questions from these concepts. So for example, if I ask a patient, who is your favorite actress? Very simple question I've asked. So the patient is speaking slowly, and the patient may say like this: sir, Alia Bhatt acts very well. I was upset for a few days when I heard she's getting married, but I'm now happy for her. May God bless her. Even Kareena Kapoor Khan is a good actress. Recently I heard some very tragic incidents in their home, and I'm sad. May God bless them. Even Katrina Kaif is a good actress. I've seen all her movies. I was upset for a few days when I heard she's getting married, but my favorite actress is Kiara Advani. So can you appreciate, the patient here has given unnecessary information which you have not asked for, although the information is making sense, you are able to understand, and finally he is answering the question. So this is circumstantiality. We'll talk about tangentiality. Yes, we'll talk about that when I'll discuss form. Very good. So here remember, the goal is reached. So that will help you differentiate it from tangentiality. See this question, recently asked question. A doctor asks a patient about her age. So see this, we are asking something. The patient responds, doctor, I am from a village. We were married at a very young age at 12 with my husband, who is just 5 years older than me. Then I had 2 kids when I was around 18 or something. Now I am 38. But look like their older sister, doctor. So can you appreciate this here? Ultimately, patient is giving unnecessary information, but patient ultimately has answered the question. So this is circumstantiality. Very good. This is circumstantiality. Very good. It is not flight of ideas. We'll talk about derailment, tangentiality also. So this is circumstantiality. Very good. I hope this is clear. Now, let's also discuss one more abnormality under flow or stream, that is perseveration. Again, very important. Let's talk about perseveration. Now, in perseveration, in fact, it's an abnormality of continuity. So, we are talking about problems of flow or stream of thought. The thoughts are flowing normally. So, here in perseveration, there is some problem in continuity. The thoughts are not moving in continuity. So, let's talk about perseveration. In fact, you can write down FQ, put a hashtag, such a new question may be asked, perseveration. Now, what is the meaning? What is the English meaning of perseveration? Somebody is perseverating, somebody is repeating things again and again. So, remember, again I always say 3 P's for perseveration. Remember, P for perseveration, a thought persists. A thought persists beyond the point of relevance. So, in the question they may tell you that the patient is answering all the questions with the same words. So, he is repeating the same answer again and again, as if he is stuck. He is not able to move forward. He is stuck at one thought. So, there is problem in continuity now. So, this is perseveration. Very simple example you can remember. Sometimes such examples may be asked. Suppose you ask a patient, what is your name? The patient replies, my name is Mukesh. This is correct. It is absolutely relevant. Then you ask, what do you do? My name is Mukesh. Where do you live? My name is Mukesh. What is the name of your wife? My name is Mukesh. Now, can you appreciate now in all the other questions, he is repeating the same answer. So, can I say that his same thought is persisting now without the point of relevance? In the other question, this thought is not relevant, but it is still getting repeated. So, this is perseveration. I hope perseveration is clear to everyone. Patient is answering all the question with the same answer. Tell me important condition, 2 important condition at least remember. And also remember the order. If I ask you one condition in which perseveration may be seen, can you tell me one condition? If I ask you one condition in which perseveration may be seen, tell me one important condition where you may find perseveration. Please remember, if it is asked one condition, remember organic mental disorder. Of course, even in schizophrenia also it may be seen, but if you are asked one, please remember organic mental disorder. So, we will talk about organic mental disorders in a while. Please remember. So, 2 points we have discussed. Even labile affect we discussed along with mania, it can be seen in organic mental disorder, even perseveration. In fact, we have kept it as number 1. Okay. So, for MCQs, remember, then you have to choose organic mental disorders first, right? I hope this is clear. So, we have covered 2 important aspects of thought. One we have covered is content, in which we discussed delusion, and few other aspects under flow or stream we have covered. In fact, this question was asked in NEET PG also. A patient was having some symptoms including flight of ideas, and in that option was mania or hypomania. So, remember there the answer was mania. Now, let us discuss the next question. So, now we will talk about the third domain of thought, that is form. Organic mental disorders we will discuss, such as delirium, dementia, even amnestic disorders. We will talk about this. Okay. So, remember delirium, dementia, these are included under organic mental disorders. Now, which of these is including informal thought disorder, FTDs? So, again, as the name suggests, so this is in fact a NEET PG question. That is why I am telling you this classification is important. Sometimes simple one-liner questions may also be asked, and sometimes they may give you a clinical question. So, can you appreciate from the name formal? Formal is telling you that there is problem in the form. So, what is the right answer? Can anybody tell me what is the right answer here? Very good. Yes. We will talk about this. The answer here is derailment. Now, let us talk about some abnormalities of form. Now, how to understand form? Let us see this. Now, form basically means organization. Like this pen I am holding, it has a structure, it has a form, it has a shape. Similarly, our thoughts, they also have a form. For example, if you pick up any of your thought, you will see that all our thoughts, they will have some start, there will be some beginning, there will be a middle part, and then there will be an end. So, if you observe your thoughts carefully, you will see that it has a start, a middle part, and an end, and everything is logically connected. That is what is known as form. So, this is the normal form of any thought. But when this form is abnormal, then we call it as formal thought disorders. Now, form, can I say that if the form is normal, can I say that the thoughts are organized? There is organization in thinking. The thoughts are organized, they are logically connected. That means the thoughts, they have a normal form, they are organized. So, can I say in formal thought disorders, when the form is abnormal, can I say that there is disorganization? There is disorganization of thinking. The thoughts are appearing disorganized, isn't it? In fact, we'll talk about this when we'll discuss schizophrenia. There, one of the symptoms in schizophrenia we'll discuss is disorganization in speech or thought. So all these formal thought disorders we'll discuss may be seen in schizophrenia. Now let's talk about these formal thought disorders. Again, I always say remember the name. The concept will be very easy to understand. Loosening of association. See this. So first we are talking about loosening of association. What is the name telling you? That the thoughts which had association, which were logically connected, now that association, that connection is loosened up. So in loosening of association, you will see there is a break in the logical connection between the thoughts. So thought which was logically connected, now that logical connection is gone. Now for example, if you ask a patient, what will you do if you want to have food outside? So the patient may say like this, sir, I will pay, I will come back, I will eat food, I will reach the cafe, I will go to the washroom, black umbrella, I will order food. So can you appreciate here, when I asked that what will you do when you have to have food outside, the patient is saying things which are not making much sense. We are able to understand words, but we are not able to understand the sentences. So there is a break in the logical connection between the thoughts. So this is loosening of association. Now also see this, we discussed one interesting question when we talk about this. So a patient says like this, can you appreciate here, I am Tom, I am a con, my friend is gone, I want an iPhone, time is done, let's call Sean, right? Now in this, they have not mentioned increased speed, isn't it? That was not mentioned, still we said it is flight of ideas. Why not it is loosening of association? So sometimes you may be asked how to differentiate between these abnormalities. Of course, one of the main differences, so let's talk about that. One of the main difference between loosening of association, and flight of ideas is the speed. We know in flight of ideas speed is increased, while in loosening of association we are not talking about abnormality of speed, the speed seems normal. But in the written question, when they have not mentioned that the speed is increased or it is normal, still we call it as flight of ideas. Very good, because we discussed that there may be some connections. Very good. Can be seen in flight of ideas, usually not seen in loosening of association. So that helped us to identify it as flight of ideas, because in both patient is saying things which are not making much sense. Yes, I hope this is clear. So that is loosening of association. Now let's talk about the second abnormality. Again, just see the name. Derailment, also known as night move thinking. Also known as night move thinking. Now just see the name. What is the meaning of derailment? So a train was moving on track and suddenly it got derailed. So this is derailment. So here what is happening, the patient, when he starts answering, he is on the track for some time and then he gets derailed. He goes to a new topic. So derailment means jumping off the track. Just remember the name and you will understand the concept. So again, if to this patient I asked, what will you do if you want to have food outside? So patient says, sir, I will book a cab, I will reach cafe. So he's on the track for some time. But rather than going on track, suddenly he changes the topic and starts saying that again now there is Champions Trophy coming up in the men's cricket team and I hope India wins this Champions Trophy. So can you appreciate, he was on track and suddenly he changed the track. So there is derailment. Knights move thinking. How does a knight move in the chessboard? It goes straight and suddenly takes a turn. This is what is happening in thinking. So for derailment, please remember, they will tell you in the question, he started with the topic and then he changed the track. In fact, if you appreciate, this was the question which was asked in the NEET PG. Derailment, it's an abnormality of form. Next time they may just ask you, a patient started on the topic and then he changed to the other topic and there is no connection between those topics. This is derailment. Is it clear to everyone? Now let's discuss, many of you were asking tangentiality. Let's talk about tangentiality. Again, I always say, see the name, tangent. Tangentiality is made up of the word tangent. Let's go to our school days. Geometry teacher would tell us draw a tangent. So what's a tangent? It's a line which touches the circle at one point and it goes away. Does a tangent ever return to the circle? Does a tangent return to the circle? No. So this is tangentiality. That means the patient just touches the topic and goes away. So tell me, The goal is reached or not reached. He touches the topic and goes away. The goal is reached or not reached. Yes, the goal is not reached. Very good. So many of you were asking how to differentiate it from circumstantiality. Remember, in circumstantiality, he gave unnecessary information and reached the goal. Here he touches the topic and goes away and does not answer the question. So the same question we asked the patient, who was your favorite actor? If we ask this patient, he may start like this, sir, I like Indian movies, especially the dances. In fact, sir, yesterday I was watching Shahid Kapoor's movie, he dances very well. And I saw Kabir Singh also, and even I am choosing to become an orthopedic surgeon. So can you appreciate, he touched the topic and he went away and did not answer the question back. This is tangentiality. Also remember, please remember how to differentiate derailment from tangentiality. In tangentiality, from the beginning, it just touches the topic and goes away. While in derailment, for some time, he is on track. So in the question, it should be evident that he is on track for some time, then he changed the track. So this is derailment. Okay, I hope this is clear. Last, let's also discuss fourth one, that is neologism. Again, just see the name. Neo, what is the meaning of neo? Neo means new. Neo means new and logos means word. So what is neologism? Neologism means new words. So patient derives a new word which is not there in the language known to the patient. Suppose I am talking to a patient and he knows only English language, and we are discussing his daily activities. So he is saying, sir, I did this in the morning, then I did this, and suddenly he starts saying, sir, I brought a new Pratt knit kit wit go and you are very confused, what is this? He says, sir, it's white in color. You are still not able to know. Can you tell me what is this Pratt knit kit wit go? You googled it, there was no such word. You opened the Oxford dictionary, there is no such word. And then he points out to his pen, sir, I bought a new Pratt knit kit wit go. So can you appreciate how the patient has given this new word to this pen? So this is neologism. Again, it can be seen in conditions like schizophrenia. We will discuss disorganization may be seen in schizophrenia. Very good. This can be seen in schizophrenia. I hope this is clear to everyone. Now, since we have understood these concepts, let's try to solve an MCQ also. Let me see if we can answer this question. In fact, again, I am telling you, I'll discuss some important relevant PYQs also from these topics so that you get an idea. When we are beginning, we should know what type of questions are being asked so that we can prepare ourselves better. A psychiatrist asked a patient, how is your mood? The patient replied, it is up and down. What is the diagnosis? Now let's try to see. So ruling out is also one important method you can use when you're solving MCQs. Is it neologism? Is it, can you see any new word which you're not able to understand? No. Can you see any rhyming? Is it clang association? No. Okay, it also does not appear clang. So tell me, how many of us say it is C and how many of us say it is D? Yes. So now our concepts will matter. See, you asked how is your mood, he has touched the topic. It is up and down does not necessarily mean he is happy and sad. It seems he has just touched the topic. I told you for derailment, it should be evident that he is on track for some time and then he has changed the track. That also is not evident, isn't it? Is it clear to everyone? It is also not derailment. Of course, it appears to be an incomplete question, but still I can say yes, he has touched the topic. So it is tangentiality here. So please be very careful when you are answering yes. Very good. I hope this is clear to everyone. I hope this is clear to everyone, making sense. Right. So yes. Now here again, he just touched the topic. Again, he has not been very clear that it is happy and sad, So that's why I'm saying it appears, you are right, that it appears, the mood is up and down. He has touched that topic. Yes. So here the answer, again this question was asked, so then we have to choose an answer. Of course, all the three options are not making sense. The answer here is tangentiality. He has touched the topic. Is it clear? Right. Now, that's why I'm saying, don't think up and down means happy and sad. He has just touched the topic. Again, that's why I'm saying it's an incomplete question, but this question is a PYQ. So they'd ask this question. So then out of the options, when I see all the other three options are getting ruled out. So the better answer here is tangentiality. That is why I'm saying try to rule out the option. Sometimes you're able to get to the right answer. Okay. Now let's come to the last domain, that is possession. Again, just see the name possession. What do you mean by possession? So normally if I ask you, the thoughts which are coming in your mind are your thoughts or your neighbor's thought, you will say, of course sir, these are my thought, I possess my thought. But sometimes there is abnormality in this. So either patient is not able to control their thought, or they may seem to think that or experience that their thoughts are being influenced by someone else. So this is abnormality of possession. Two important abnormalities I'll discuss. One is obsession. Please remember, for all practical purposes, if you are asked, obsession is an abnormality of possession. In some books, it is also kept under content. So better answer will be possession more than content of thought. So can anybody tell me what are obsessions? Obsession means patient is having some repetitive thought. So patient says, sir, there are some thoughts in my mind coming again and again, 2 hours, 4 hours every day, or some images are coming in my mind, or impulses. What are impulses? Again, this was a PYQ. What are impulses? Impulses are urges, irresistible urges. This was also asked previously, that what is an irresistible urge known as? That is an impulse. So obsessions may be repetitive thought, images, or impulsive, but the patient is not able to control. So that is why it is coming under obsession. Where do you find obsessions? Which condition? Very good. Yes, Rosie is the mnemonic we discussed. Very good. I am happy you remember the mnemonic as well, right? So in OCD, you know, they may give you a case of OCD. In fact, that has been asked previously in NICT, and it asks, it's an abnormality of flow, form, content, possession. The answer is possession. One more abnormality which you can remember is thought alienation. So remember one more abnormality, thought alienation. Again, see the name. The thoughts are alien, as if my thoughts are not my thoughts. They are influenced by someone else. This in fact is also known as, remember, passivity of thought. Thought alienation is also known as passivity of thought. Passivity of thought. Again, in psychiatry, whenever you read this term passivity, it means under someone else's control. So remember this name also. When you will read, in fact, schizophrenia, you may come across certain terms. So passivity, remember, that means it is under someone else's control or influence. So passivity of thought means my thoughts are under someone else's control. So three abnormalities come here. One is thought insertion. Very simple. Patient says that someone is inserting thoughts in my mind. Patient says, sir, there is a thought in my mind, but it is not mine. Somebody has put this thought inside me. Thought withdrawal, very simple to remember. Just see, in thought withdrawal, patient says somebody is withdrawing thoughts from my mind. So there was a thought in my mind few minutes back. I don't know what it was. Somebody has taken that out, taken it away. What is thought broadcast? Here the patient claims, here the patient says that my thoughts are getting broadcasted outside through radio, newspaper. Everybody is able to know my thought. So in the question, if they say like this, the patient thinks that everybody in the room is able to know his thoughts. His thoughts are getting broadcasted outside. This is thought broadcast. Again, thought alienation. Can you tell me where can this be seen? Thought alienation phenomena, it may be seen in conditions like schizophrenia. So this is again a very important table which we have just discussed. I have discussed some important abnormalities of flow, content, form and possession. Again, as you have seen, questions have been asked. Now let's discuss a very interesting question. This is what I am trying to say again and again. They are framing some newer questions. Don't look at the options, just first see the question. A patient believes that his feelings and thoughts are controlled or influenced by an external agency. So, you know, when you're thinking, when you're reading this question, it is telling me maybe you're thinking about thought alienation phenomena. But look at the question. They have not asked any, you know, such phenomena. So they have in fact given you 4 delusions and you have to mark the answer accordingly. So can you tell me what is the right answer? This is what I'm saying, you know, some newer questions when they come, try, you know, not to panic and try to see the options, because you know that it is not delusion of nihilism. You're very sure it is not delusion of nihilism. You also know it is not delusion of reference. You also know it is not Othello syndrome. So remember, it is delusion of influence. In fact, it's a subtype of delusion of persecution where the patient thinks has, you know, these delusions that is, you know, somebody is controlling him, you know, his thoughts or, you know, his feelings, somebody is controlling it. So this is delusion of influence. So please remember this, very, very important. I hope this is clear to everyone. If such questions come, don't worry, try to rule out the option, then you'll get to the answer. Okay, so we have covered one very important topic. Again, I am saying it's a very important topic. Please be very careful. You will see one or the other questions, or delusion may come as a symptom also in the patients. You know, it's a psychotic symptom we have discussed. Now let's come to another important topic. Tell me what is the answer here. What is the phenomena? A patient says that he can hear a voice coming from just outside of his room. So he is able to hear somebody's voice from outside of the room, of a man who is abusing him. So he's hearing a voice of a man who is abusing him coming from just outside his room. But when he looks out, there is no one and no one else can hear that voice. Can you tell me what is this phenomena? Very good. And you are also telling me the type. Very good. This is hallucination, and in fact here it is auditory hallucination. Very good. This is auditory hallucination. So let's now discuss perception. Let's talk about abnormalities of perception. So hallucination, please remember, hallucination is also a psychotic symptom. Very important to differentiate delusion from hallucination. You know, sometimes you get confused. You know, both of them are psychotic symptom. Please remember, delusion is a problem of what? It's a false thought. You know, I always say just go back to the basics. It's a false thought. It is a false thought. It's a false belief which the patient is having. While hallucination is a false, it's a false perception. It's an abnormality of perception. Perception means the way we experience the external environment. So we can perceive the external environment. You know, we can hear. So there is auditory, visual. You know, you can smell, that is olfaction. You can taste, gustatory, and you can touch, that is tactile. So you can see me, you can hear me, you can touch things around you, you can smell, and you can taste things. So that is perception. So when the person is having problems in perception, then you may think of hallucination. While delusion is a false thought. A patient says, please see this again. A patient says that my neighbor wants to kill me. I am sure, I am definitely 100% sure my neighbor wants to kill me. Everybody is trying to convince him otherwise, but he is convinced that neighbor wants to kill him. Can anybody tell me what is this known as? What is this known as? So patient says he's sure that neighbor wants to kill him. What is this? Anybody? What phenomena you can see here? Very good. It's a delusion of persecution. Very good. In another situation, patient says, sir, I can hear the voice of my neighbor. They are planning to kill me. So what is this now? Can anybody tell me? What is this? He can hear the voice of his neighbor. They are planning to kill him, he says. He can hear the voice, isn't it? So this is hallucination. Here it is auditory hallucination. I hope the difference is clear to everyone. Okay, because both are false. You know, patient will not get convinced in either of them. Okay, you say no, I cannot hear any voice, but he'll say I am hearing a voice. Similarly, in delusion of persecution, he is convinced. Okay, so both are false, both are psychotic symptoms. Remember, one is thought, another is perception. Very good. Now let's discuss hallucination. So it's a false perception, as we discussed, without any real object. So there is no real object, but the patient is experiencing some perception. Like in this case, there was no voice, but he was experiencing it. Okay, so this is hallucination. Now also let's try to understand one important point. So hallucination, before coming to the types of hallucination, let's also talk about pseudo hallucinations. Now, in both hallucination and pseudo hallucination, both have a lot of similarities. Both are very clear. Like in this case, patient will say that whatever the person is saying, he is hearing the voice, he will hear it very clearly, that what that voice was saying, whether it's a male voice or a female voice, young or old voice. And patient says, sir, it is not dependent on my will. Sir, it is coming and going on its own. It is not dependent on my will, and also it is occurring without any real object. So both of them have some commonalities. But what is the important difference? Can you tell me? Hallucination, where it is occurring outside. Na? Like this patient is hearing the voice coming from just outside the room, or maybe just within the room, or maybe just from the first floor. Okay, so it is occurring in the outer objective space. While where pseudo hallucination is occurring, remember, it is occurring in the inner subjective space. So you will ask, sir, how to differentiate? So in pseudo hallucination, patient may say, sir, I am hearing a voice which is clear, not dependent on my will, without any real object it is, but it is coming from within. It is coming from within in the inner subjective space. Sir, I can see someone standing in the room. Can you tell me what is this? Patient says, I can see a man standing in the room. Nobody else is able to see that man. What is that? Can anybody tell me? Can anybody tell me? Hello? Yes, welcome again. So tell me, patient is seeing someone in the room. Nobody else can see. This is what? This is, yes, this is visual hallucination. Patient says, I can see a man very clearly, not under my control, you know, and it is in my mind, in the inner space, in my mind space, I am able to see. Then that is pseudo hallucination. So ask where he is experiencing it. Is it clear to everyone? Very good. Yes. Now let's talk about the types. So we discussed there are 5 important sensory modalities. Based on that, there are 5 types of hallucinations. So very simple. Person is hearing something, it is auditory. Patient can see something not seen by others, visual. Tactile, touch, patient is experiencing touch sensation. Olfactory means smell, gustatory means taste. Very good. Okay, very good. Now tell me one important point. Again, we have talked about this. Hallucination is a psychotic symptom. It can be seen in psychotic disorders like schizophrenia and other conditions also. Now, if I ask you, a patient comes to you with visual hallucination, any important diagnosis is coming to your mind. Of course, visual hallucination can also occur in schizophrenia. But one important point which I want you to remember, if a patient is in the MCQ is having visual hallucination, one important abnormality which we need to see. Very good. So, I am very happy. Congratulations. You passed this exam. Yes, we saw in LRR, I think all the questions were from LRR. Thank you so much for joining in. So, can you tell me visual hallucination? Yes. So, please remember organic mental disorder. Very good. We will talk about this. In fact, they are framing many questions from just this point. So, I am trying to say, if a patient comes in the MCQ with visual hallucination, try to see if he is having any organic mental disorder. Okay. Now, tactile hallucination, that is touch. Touch. Can anybody tell me what is this also known as? This is also known as formication, also known as cocaine bugs or magnum bugs. Why it is also known as cocaine bugs? Anybody? We'll discuss this when we'll talk about substance use disorder, because it may be seen with cocaine users. You know, in fact, a question was asked previously, a patient having tachycardia, tachypnea and scratch marks. Which substance he is consuming? I'll discuss this again when we'll discuss substance, but can you tell me what substance it could be? He's having scratch marks. So maybe he's having tactile hallucination and he's scratching. So you may find, yes, scratch marks. So remember, sometimes you may find scratch marks. Okay. Then olfactory means patient is smelling something, there is no smell but the patient is smelling, and there is no object on his tongue but he is able to have a taste, that is gustatory. Again, tell me, olfactory gustatory hallucination, patient had a recent road traffic accident, he had a head injury and he developed these hallucinations. Which important area of the brain you may think of? Okay. Liquor based liquor, thank you so much, many congratulations. Tell me which area of the brain abnormality you are thinking. You know, again such questions may be framed. You know, he has a head injury, a CT or an MRI is given, he is developing olfactory gustatory hallucination. Very good, in the temporal lobe disorders. Other hallucinations can also occur, but remember, in temporal lobe disorders, even in temporal lobe epilepsy, you know, sometimes patient may have these symptoms. Very good. Again, if I ask you which is the most common hallucination in psychiatric disorders, then you will go with auditory, most common. While if I ask you most common in organic mental disorder, in organic mental disorder most common you can say it is visual hallucination. I hope this is clear to everyone. Now, there are various special hallucinations, special because they are different, slightly different from the, you know, normal types of hallucination we are seeing. So, let's discuss one special hallucination. Now, tell me this phenomena. A patient says that whenever he turns on the radio, that means whenever he switch on the radio and he hears the radio, so he is hearing radio, radio here is the real, it's a real stimulus, it's a real object, he see color in the air, he see color in the air. Okay. Okay, again you can go with auditory, Khushi, yes. And tell me this phenomena, what is this phenomena? Normally we discuss that hallucinations, they are not dependent on any object, but here we are saying that a hallucination is occurring only when there is a real stimulus. So this is a special hallucination known as reflex hallucination, also known as morbid synesthesia. Very good. So here can you appreciate when he is hearing, so here what is happening? A normal stimulus in one sensory modality, like in this case the normal stimulus was in auditory modality, it is producing, it is provoking hallucination in a different modality. So here the stimulus was auditory and the hallucination which he saw, it is visual hallucination. So this is reflex. If it would have occurred in the same modality, then we call it as functional. In functional hallucination, if it is in the same modality, that means if he is auditory stimulus, he says when I turn on the radio, I hear the voice of another person. So when I turn on the radio, I am also hearing the radio and I also hear a voice of another person. So it's in same modality, then we call it as functional, but here it is reflex. So whenever he turn on the radio, he says I see color in the sky. So this is reflex. As a reflex the hallucination is occurring, also known as morbid synesthesia. Now tell me one important substance it may be associated with. So it may be associated with certain substances such as hallucinogens, remember, such as LSD. So reflex hallucination, morbid synesthesia may be associated with hallucinogens like LSD, lysergic acid diethylamide. So LSD, it's a hallucinogen, lysergic acid diethylamide. LSD in fact is also associated with certain other phenomena such as flashback phenomena, also associated with bad trip. Flashback means currently today he is not consumed LSD, few weeks back, few days back he consumed, and that experience has come now again as a flashback. So without any substance he is enjoying its effect. So this is flashback. Bad trip, sometimes patient may develop. Usually when the patient takes, he experience euphoria, he experiences pleasantness, but sometimes he may experience some unpleasant symptoms like anxiety. That is known as bad trip. So remember some of these phenomena associated with LSD. Okay, now see this question which was asked last year. A patient consuming a substance reports of seeing red color when he hears the radio. So very simple now. So this is a reflex hallucination. Again, if you have to choose one, go with LSD. I hope this is clear to everyone. So we have talked about abnormalities of thought, some important abnormalities of perception also we discussed. Now let's discuss some cognitive functions. So let's now complete the MSc, let's complete the basics, then we'll go to the important disorders. I hope this is clear. Now let's talk about some important cognitive symptoms. Here itself, remember, so we are now assessing cognitive symptoms or higher mental functions of the patient. So remember, we'll discuss these cognitive symptoms, they may be impaired in organic mental disorders. So when we'll discuss organic mental disorders, we'll discuss that these cognitive functions may be impaired. In fact, you will appreciate this, that the now newer term for organic mental disorder is neurocognitive disorders. Now can you appreciate, the name is telling you that there is some cognitive impairment. So neurocognitive disorder is a new term used for organic mental disorder. So can you appreciate the cognitive symptoms are impaired in neurocognitive disorder. Now first let's talk about orientation. Orientation basically means awareness of self and surrounding. Right now all of us sitting in the session, we are aware, who are we, where are we, who are people around. So this is orientation. How we check orientation? So we ask the patient time, place and person. So this is orientation. Now remember, suppose a patient admitted in the hospital, you ask him where are you and he says I am at my home. So patient is in the hospital but he is saying I am at my home. So he is disoriented to place. Can you tell me disorientation? Disorientation. Can anybody tell me one important condition wherein you may find disorientation? Remember, D for disorientation. D for anybody? D for disorientation. Tell me one important condition. In fact, that is a neurocognitive disorder. So you can, very good. D for delirium. Very good. So we'll talk about this. So can you appreciate delirium? We are saying that it's a neurocognitive disorder. So these cognitive impairments may be seen in the neurocognitive disorder. Now second is, let's talk about attention. Again, always try to understand the term and you will understand the concept. What is attention? In school days, teacher would come in the class and teacher would say, pay attention. So what is the teacher trying to say? That focus on my voice. So attention means ability to focus on a particular stimulus. So this is attention. Now the question which they ask is how we check attention in a patient. Remember, one important test which you can remember. Yes, very good. Digit repetition or digit span test. The name is telling you. Digit means numbers, so we give numbers to the patient and we ask the patient to repeat them. So again, there are two ways. One is the digit forward method, forward test. So suppose I tell the patient 2, 7. He has to repeat in the forward direction. So he will also say 2, 7 and then I will increase the numbers. And another is, remember, another is digit backward test. In digit backward test, what we do? We again give the number to the patient and ask the patient to repeat in the backward direction. Suppose I say 3, 8, he will say 8, 3. Then I will increase the number. So these are the tests we use to assess attention. Again, if one is asked, both are given in the option and you are asked to choose one, then digit forward test is a better answer for checking attention. A psychiatrist is asking a patient, to repeat some numbers after him. What is the psychiatrist assessing? He is assessing attention. Now let's talk about what is concentration. This was again asked in one of the recent exams. Concentration, again, just see the name. Sometimes you say, no sir, after reading for half an hour, I lose my concentration. So that is concentration, sustained attention. So how do we check concentration? By performing tests like serial 7 subtraction test or 100 minus 7 test. We tell the patient, yes, so we tell the patient subtract 7 out of 100, whatever answer comes, keep on subtracting. So जो भी answer आएगा उसमें से 7 subtract करते जाओ. If he is able to do this, that means he is able to sustain his attention, that means his concentration is intact. Normally we say, normally people are able to do it at least up to 5 times. So this is concentration. This was asked, a psychiatrist is performing 100 minus 7 test, what is he assessing? It was concentration. Now also let's talk about memory. Again, memory we can divide into 3 based on the duration. Immediate memory means memory of the past few seconds. Recent means memory of the past few minutes, hours or days. While remote, remote means something which is very far. So remote memory means memory of months or years. So how do we check immediate memory? Remember, we don't do any specific test. The test of attention and concentration are also indirectly checking the immediate memory. But if they ask you one specific test, then remember digit forward test will be a better answer. Recent, very important, please highlight recent. Recent means memory of past few minutes, hours or days. Usually the test which we do to check recent memory, it is 24 hours recall method. So we ask certain things which happened in the past 24 hours. Very commonly we ask the patient, what did you had in your last meal? Suppose if I ask you, what did you had in your last meal? You will be able to tell me, na, sir, I had this, I had, chapati, I had rice, so that means your recent memory is intact. So if they want to ask new question, they may ask like this, you are asking a patient who came to meet you in the morning today. So again you are asking some events which happened in the 24 hours, na, you are checking his recent memory. While remote memory, how do we assess? By asking some personal information. So suppose I am asking a 70-year-old male, name of his school. I am asking name of his school friends, okay, name of his wife, his children, so again I am asking all these old information. So basically I am assessing what? I am assessing remote memory. I hope this is clear. In fact, we will discuss dementia. In dementia, memory impairment can occur, amnesia can occur, and many times you will see, for example, in Alzheimer's disease, initially patient may come with more of recent impairment of memory, recent memory, immediate memory, they are impaired. Remote memory, they may still remember. It may be last to get affected, sometimes. So again, we assess memory. I hope this is clear to everyone. So when they ask such questions, they may ask you, what are we assessing? Let's continue with, some of the important other headings of MSc. Now let's talk about abstract thinking. Now what is abstract thinking? Now many of us might have gone to art gallery. You go to any art gallery, you will see such paintings hung up on the wall and people may be staring for hours and hours. Somebody will say, I can see this in the painting. Somebody says, I can see this in the painting. So that is abstract art. So abstract thinking means ability to understand hidden meanings or ability to form concepts, that is abstract thinking. So all of us have abstract thinking, we are able to understand hidden meanings, we are able to form concepts. Now please remember some important tests. Usually again, they may ask you test to check abstract thinking. Can anybody tell me any test we use to check? Very good, yes. So we ask proverbs, very good, we ask proverbs, proverbs means muhavre. For example, if I ask you pen is mightier than sword, what is the meaning of this proverb? Anybody? What is the meaning of this proverb? Pen is mightier than sword, है ना? सबने सुना ये कलम की ताकत तलवार की ताकत से ज़्यादा होती है ना? So this proverb means what? You will say, sir, it means that intelligence is more powerful than muscle. But suppose patient says, sir, I will tell you the meaning. It means that if I am fighting with someone and I am holding a pen, other person is holding a sword, I will win because I am holding a pen. Does this mean that? No. That means he is not able to understand the hidden meanings. That means abstract thinking is absent. Can anybody tell me what is this term known as when the abstract thinking is impaired? What is this known as? It is known as concrete thinking. Concrete thinking. So when you will solve questions, you will see that such terms may be given. So concrete, concrete means superficial. Patient is not able to go deeper, is only able to understand the superficial meaning. Okay, so loss of abstract thinking is concrete thinking. Okay, again it may be seen in certain psychotic illnesses, it may be seen in psychosis like schizophrenia, even in other conditions. So it may be seen in schizophrenia. One more test you can remember which we do is similarity testing. So one more test to assess abstract thinking. So we ask similarity between two objects. Suppose if I ask you similarity between a car and a plane, what will you say? What is the similarity between a car and a plane? Can anybody tell me? So I am asking you the similarity between a car and a plane. So can you tell me what will be the similarities between a car and a plane? So you will say, sir, both of them are mode of transport, isn't it? So you are able to see the functional similarity. That means your abstract thinking is intact. Very good. Now suppose a patient is only able to see the structural similarity. Patient says, sir, both of them are tires. Both of them are made up of metal. Can you appreciate he is only able to see the superficial similarity? So in this case, I will say that his abstract thinking is impaired. That is, there is concrete thinking. So these are the two tests. So they may just ask you that these tests are being performed and what we are assessing. Okay. So we have discussed abstract thinking. Let's also discuss what is judgment. Very good. Mode of transport. Very good. They are vehicle for modes of transport. Very good. Now judgment basically means ability to take the right decision. Now there are various types of judgment. Let's discuss one of them, that is test judgment. Now as the name suggests, in test judgment what we do, we take a test. We give an imaginary situation to the patient and ask him what he will do. So very commonly, we can ask question like this fire problem. Suppose I ask you, what will you do if your neighbor's house catches fire? So it's an imaginary situation. I am asking you what you will do. So what will you do in that situation? Tell me. So many of us will say, sir, we'll try to help the neighbors, we'll call the fire brigade, we'll try to extinguish the fire, isn't it? So all these are telling me that your judgment is intact. One patient says, sir, what I will do? I will pour kerosene in the fire. So tell me here, judgment is intact or impaired? It seems impaired. So remember, impaired judgment may be seen in psychosis like schizophrenia. Okay, so this is judgment, test judgment. I hope this is clear to everyone. Now last point in the MSc, let's also talk about insight. Insight means, what is insight? Awareness of illness. Now sometimes in psychiatry, patient may come and say, sir, I am not having any problem. I think my family members have having some problem. You check them, but actually the patient is having some problem. So patient may not be aware of the illness. So again, we'll talk about this. Psychiatric illnesses may be neurotic illnesses, neurosis and psychosis. Tell me where insight is present and where it is absent. Insight is present where, absent where. In neurosis, tell me insight is present or absent. Remember, it is present in neurosis and it is absent in psychosis. So these were some important headings of the MSc which we have discussed. I hope it is clear to everyone. So when we are beginning to read psychiatry, understand psychiatry, it's very important to read MSc to know all these important terms, because when we'll discuss the disorders, you will come across these terms. Okay. Now let me talk about some classifications. Now when we talk about the diagnosis, when we will discuss to make a diagnosis, the more current classification, we have two classifications. One is DSM-5, Diagnostic and Statistical Manual of Mental Disorders. 5 is it's the latest edition, and one we have ICD-11. So earlier there was ICD-10, now we have ICD-11, International Classification of Disease. So usually when we make a diagnosis, we follow these classifications. But now I am going to discuss a older classification, an old way of classifying psychiatric disorders, but this will be very useful for understanding the concept. Now this slide again is very important for understanding some points, some concepts. Let's see this. Now psychiatric disorders previously, they were classified into organic and functional disorders. Okay. Now when we say organic means something, very good evening, something which has a visible cause. That means the cause is visible. For example, let us say somebody had a head injury and he developed some psychiatric symptoms. So you can see the head injury, the cause is visible. Suppose somebody developed encephalitis, there is infection, inflammation of the brain parenchyma. Again, you can see the infection, you do investigations, you will see the infection, so you can see the cause. If you've seen cases of hyponatremia, sometimes you'll see when the sodium levels go below 130, the patient may develop certain psychiatric symptoms. So you check the sodium levels, you will see the cause. So that is known as organic. Okay, so some of the disorders which we will discuss, such as delirium, dementia, even amnestic disorders. So here we can say that the cause is visible. So these are organic disorders. While functional we say when there is no visible cause. Please remember, I am not saying they don't have a cause. Of course, we will discuss nowadays all the psychiatric illnesses, even those which were called functional earlier, all of them have cause. Maybe at genetic level, at neurotransmitter level. But sometimes when you will do the basic investigation, you may not find any cause. So the cause may not be apparent. So that is the meaning of functional. So again, it may be further divided into neurosis and psychosis. Now let's talk about this table. Now tell me some important points of difference. Insight is present where and absent where we have just discussed. So insight is usually present here and absent here. Judgment also we talked about, like test judgment, usually it is intact here while it may be impaired here. Delusions, hallucinations, can you appreciate, we have been saying again and again, these are psychotic symptoms. So usually they are absent here and they are present here in psychotic illnesses. Now reality testing means touch with reality, whether the person is able to differentiate what is real, what is unreal. So neurosis, usually we say reality testing is present, here it may be impaired. So these are just some point of differences. Now tell me some examples. Can you tell me some examples of neurosis, of neurotic conditions? Anybody? Can you tell me some important examples of neurotic conditions? Yes, very good. Some of the examples such as anxiety disorders, isn't it? Such as anxiety disorders, even OCD. So, when you will read those disorders now, try to understand, in the main videos, in the rapid revision also, what I've done is, we have discussed these in these categories so that you have an idea. Even some of the other disorders like somatoform disorders, we'll talk about these. We have talked about, in fact, in the videos, somatoform disorders. Even you can say depression, again, that is, more of having features of neurosis. While if I ask you some psychotic illnesses, very good, yes, OCD is there. Psychosis, I'm sure one you can tell me straight away, you can say, sir, schizophrenia is a psychotic illness, isn't it? Even others such as acute psychosis is a psychotic illness. Delusional disorder, you can say, sir, it's also a psychotic. Even bipolar disorder, call it mania or bipolar disorder, again, you can say it has some features of, psychosis. But can you appreciate, we discussed that even in depression, we discussed one delusion. In fact, there are other delusions, even hallucinations can occur. So depression may also have features of psychosis, that is known as psychotic depression. So again, it's not a very crystal clear classification, it's an old way of classifying, but still remember. So how you can remember, when you will read the psychiatry topics, you can, understand, you can see the organic disorders, you can see the neurotic disorders, psychotic disorders, so that in your mind you have an idea which is which. Sometimes simple questions may be asked from this classification. Once they had asked one question, depersonalization, derealization, which is a neurotic disorder, okay, and they had asked which is a false statement. So the question was depersonalization, deneuralization, which is a neurotic condition, and they had asked false statements. Some of the statements were very new, but still in that, one of the option was that reality testing is impaired. So they had asked you a neurotic condition and they talked about reality testing. They said reality testing is impaired and you have to choose a false statement. Isn't it a false statement? Yes, because we know reality testing is intact here in neurotic conditions. So sometimes, just by knowing this classification will help you solve concepts, questions, and also when you read the disorders like this, it will help you, form concepts in your mind, so that when you're solving question, you are able to know, yes, it's a psychotic condition, it's a neurotic condition, it's an organic condition, and then subsequently you can mark the answer. I hope this is clear to everyone. It's a very important slide, I say. Please remember it so that we are able to understand these disorders like this. So again, we'll talk about some important neurocognitive disorders. Today we'll talk about schizophrenia, we'll talk about some mood disorders, and lastly we'll discuss substance use disorder. I hope it is clear. Now let's start with the first important group of disorders, that is organic mental disorders. And now both in DSM-5 as well as in ICD-11, they are known as neurocognitive disorder. I am sure now you can appreciate the full name. Cognitive means there is some cognitive impairment, isn't it? And neuro means, I told you, organic disorder means there is a visible cause. So there is some neurological cause to these cognitive impairments. So this is neurocognitive disorders. Okay, let's talk about the first and very important topic, delirium. Delirium, in fact, is the most common organic mental disorder. It has a sudden acute onset. You will see in the question, in clinically also you will see the patient is developing the symptoms suddenly. And the course, when you see, the patient may have a fluctuating course. Fluctuating course means that you will see the symptoms, they are increasing, decreasing over time. Okay, they are not stable. So the course is fluctuating. Again, in delirium, many times you will see some risk factors being given in the question. There may be some risk factors. For example, they may tell you, so in delirium you may find some risk factors. For example, they may tell you that patient is an elderly person. So in elderly age it is more common. You know, sometimes they will mention some surgical illness. Many times you will see in surgical illness, or after some surgery the patient has developed symptoms, or you know, after road traffic accident, or in the post-operative period patient has developed symptoms. Sometimes substances such as alcohol may also be associated. So these risk factors may be given in the question. But let's understand how to identify delirium. Remember, we said it is a organic mental disorder, so cognitive impairment. So please remember this very important point, that the consciousness is impaired in delirium. Now this is very important. So in delirium we are saying that the consciousness is impaired. Now I will tell you, I will give you a list of some points. If any of these points are mentioned in the question, they are telling you, they are suggesting that there is consciousness is impaired, and then you have to think of delirium. So for example, they may tell you in the question that there is clouding of consciousness. In the clear sky of consciousness, now there is clouding, or there is altered sensorium. One point we already discussed, D for delirium, D for disorientation. So patient is admitted in the hospital but he is saying he is at his home. Or sometimes nowadays they use this term confusion, patient is appearing confused. So any of this term mentioned, this is suggesting that the consciousness is impaired, think of delirium. Is it clear to everyone? Very important point, you know, to identify delirium. And since it's a neurocognitive disorder, even cognitive impairment is there. You know, so for example, memory is impaired, language is impaired, even perceptual abnormalities you can see. Can anybody tell me which perceptual abnormality you will see more here? Anybody? Which perceptual abnormality will you see here? Okay, which perceptual abnormality? You can see here, yes, sundowning is also, yes. Which perceptual abnormality we discussed na in organic mental disorder? Very good. Okay, yes. Can you tell me? Visual hallucination. So patient is admitted in the hospital and patient is, yes, you know, visual hallucination we discussed. The perception, remember, perceptual abnormality I am talking about, hallucination. Okay, so please remember this clinical picture. Also remember in the treatment of delirium, you know, it is a medical emergency, you know, patient can die, but remember it is reversible. Now in the treatment, first is you treat the cause, you identify the cause, whatever is the cause you treat it. If they ask you in drugs, very good, yes, hallucination. If they ask you drugs, so remember patient may have hallucinations, delusions, agitation, patient is very agitated. So antipsychotics can be used. Most common antipsychotic used is haloperidol. Haloperidol is the first generation, this was asked last year, haloperidol. Even other drugs like olanzapine can be used. Can anybody tell me benzodiazepine? Benzodiazepine may be used for one particular type of delirium. So we will discuss alcohol related delirium. Can anybody tell me what is the term we use for alcohol withdrawal delirium? For alcohol withdrawal delirium, what is the term we use? It's one of the favorite questions they ask. The topic of alcohol we'll discuss today. So that is known as delirium tremens. Very good. For delirium tremens, yes, you can use benzodiazepines. Okay. So this is delirium. For managing some of the symptoms, we can use these drugs. Now there is one important differential diagnosis which I want you to remember. Patient has an acute onset of symptoms, he has fever and also has developed delusions, hallucinations. So please try to appreciate this differential diagnosis. There is one condition which may appear to be very similar to delirium. That means it also has a sudden onset. Fever, you know, fever can be given in delirium. You know, there is something organic, some physical illness is there. So fever can occur even in delirium, and delusion, hallucinations can also occur in delirium. So can you tell me what is this another condition? What is this another condition? Please try to, you know, focus on the weakness, try to, you know, do the PYQs, try to see where we have missed the point, and things will, you know, again be corrected. Don't worry, you know, this, you know, comeback will always be greater. right? Now tell me, what is this condition we have been discussing? What is this? Acute psychosis. Very good. Now how will you differentiate this? How will you differentiate acute psychosis? Please remember, if somewhere in the question they have mentioned there is consciousness being impaired, then I would have choose delirium otherwise. So please remember, fever can also occur even in acute psychosis. Okay, I hope this is clear to everyone, right? Try to focus, but again try to focus, identify which areas we can improve. And again, I've seen students doing really well. Don't worry, you know, you're not able to do well, again strategize, plan, and you will be able to, you know, do well. Now let's come to one more important stressor is there. Very good. Now one more important neurocognitive disorder which we'll discuss is dementia. Now please appreciate this. In delirium we said that consciousness is impaired and even cognition is impaired. But in dementia, so consciousness, cognition both are impaired, but in dementia we are saying only there is cognitive impairment. That means the consciousness is usually intact. So there is only cognitive impairment. So patient may come to us with various symptoms such as amnesia. Can anybody tell me, but what is amnesia? Can anybody tell me what is amnesia? So this is, dementia is a term which you will also, very good, mostly it is insidious onset. Dementia is a, you know, again diagnosis which you will also read in medicine, you know, you will also read some points in patho, in pharma. So many times you will see questions from dementia also. So amnesia means there is problems in the memory. Very good. What is aphasia? Yes beta, we are trying to, you know, this session is basically, you know, for those, you know, how to prepare well. So that is why I am discussing these topics in detail, you know, try to follow it. Aphasia, what is aphasia? There is problem in language. So family members report that the language, you know, problems are there. What is apraxia? So praxia means movement. There is problem in fine movement. Family members may tell you that the patient is not able to comb the hair, the patient is not able to button his clothes, untie the shoelaces. So there is some problem in the movement, learned movements, praxia. Very good. What is agnosia? Agnosia, patient is not able to identify, object. You know, you might have done this when you are doing neurological examination. You know, ask the patient, what is this I am holding? You ask him to identify object, he is not able to. Sometimes patient is not able to identify faces. What is that known as? Remember, that term is prosopagnosia. So remember, that is also, you know, agnosia is coming. Patient is not able to identify faces. Very good. Yes. So, you know, in fact this was asked last year in the FMGE exam. In fact, what is prosopagnosia? This question was asked. Okay. Now, let me just check. Just give me a second. I think the battery. Right. So I hope this is clear. Prosopagnosia. So this is, so can you appreciate, in dementia usually the symptoms occur insidious onset and there is only cognitive impairment. Okay, I hope this is clear. Now dementia, I will discuss some more points. Many times you will see questions from dementia. So let's see. In dementia usually we say that the symptoms are progressive, but there are 10 to 15% cases in which the dementia is reversible. Now this is a very important table. You know, some important reversible causes. You will see recently when you do PYQs, questions being asked from this table. Okay. In NICT and in even FMG, you know, many questions were asked. So reversible means usually we discussed that the dementia symptoms are progressive, but some causes of dementia, if you are able to identify the cause, treat it, the symptoms are reversed. So let's discuss some reversible causes. One is neurosurgical, such as, what is SDH? Anybody, what is SDH? Okay, around 3 hours. So this today, you know, I am planning, the session is for up to, you know, around 3 hours I am planned, so that, you know, we are able to understand, you know, when you are starting psychiatry, you have, you know, good grasp on these important topics. SDH, subdural hemorrhage. Very good. Patient has developed dementia due to brain tumor, brain abscess. You treat it, dementia will be reversed. Another is NPH. Can anybody tell me what is NPH? Very good. NPH is normal pressure hydrocephalus. Normal pressure hydrocephalus. You correct it, dementia will be reversed. Again, you know, may be corrected by ventricular shunting. Again, there is a triad of symptoms in NPH. Cognitive impairment, as we are discussing, gait abnormality. There may be magnetic gait and even urinary incontinence, also known as Hakim or Adams triad. So remember NPH. NPH again was asked. NPH is reversible or irreversible if it is asked dementia. This was asked in NICT exam. remember it is reversible. I hope this is clear. SDH is subdural hemorrhage, subdural hematoma, very good. Okay, now then there may be certain causes which are infections, so such as encephalitis, meningitis, patient developed dementia due to that, you correct it, dementia will be reversed. Now in metabolic cause, this is very important. Deficiency, there is one very important deficiency which I want you to remember. Anybody? So there are many vitamins deficiency whose can cause dementia. One important, if it is asked, anybody, which vitamin deficiency I am talking about? Remember, vitamin B12. Even other vitamins you can remember, niacin, folate, even B1, that is thiamine deficiency can cause. But if they ask one, remember vitamin B12. Even there are endocrinal abnormalities. Please remember even endocrinal abnormalities such as hypothyroidism. Again, if one is asked, so please remember hypothyroidism can also cause reversible dementia, reversible cognitive impairment. Even hyperthyroidism, even hyperparathyroidism. Again, if one is asked, you can go with hypothyroidism, but if the option is all, then all of these can cause reversible dementia. Now, very good. In others, I want you to tell me one important substance. So I am saying that patient is consuming one substance and he has developed dementia. You tell the patient stop that substance, maybe within a year, whatever changes which occurred in the brain, that may also be reversed. So can you tell me which dementia we're talking about? Yes, Parkinson disease can cause dementia. Yes, we'll talk about that. Substance, I'm talking about substance. Remember alcohol. See, even alcohol can cause dementia, and many times we see that it may be reversible. In fact, we'll discuss other neurocognitive disorders due to alcohol. We'll discuss Wernicke's, we'll talk about Korsakoff, but remember even alcohol use can cause dementia, which is reversible usually. Is it clear to everyone? Very good. Yes. Now see this question. Sometimes when they are asking questions, they may not ask the question directly. So that is why I am keeping these questions in the slide so that you have an idea. When I say dementia, you will say, sir, dementia means cognitive impairment. So the question is, deficiency of which of the following is the reason for cognitive impairment in old age? Now again, we know usually, jaise we discussed, delirium also more common in elderly, even dementia may be more common in elderly. So they are indirectly asking you dementia. And which deficiency, if they ask you, one they ask you to choose, remember vitamin B12. So please try to understand what they are asking in the question and then try to answer the question. Okay. So they may not ask you directly. Sometimes such statements are given in the question and you have to choose a answer. Very good. Now let's see one more classification. So we discussed, some reversible causes, then most of the others are usually progressive. Now let's also talk about one more classification of dementia. Sometimes this is also asked, again very important. So sometimes we can divide dementia based on which area is involved, cortical and subcortical. Cortical means the cortical or the cortex is involved first, and later on even the other areas are involved. And in subcortical, dementia, the subcortical grey matter such as basal ganglia, that may be involved, thalamus, these areas are involved. Now can you tell me some examples? Usually the question which they ask, many times you've seen examples. Tell me some examples of cortical dementia. That means here the cortex is getting involved first. So please remember, if I ask you in fact what is the most common, overall most common cause of dementia, what is the answer? Let's discuss here only. If I ask you which is the most common cause of dementia, anybody? What is the most common cause of dementia if I ask you overall? Remember, very good, it is Alzheimer's disease. Very good, this is the most common. Now if I ask you the second most common, now the answers have slightly changed. If they ask you now second most common, earlier it was vascular, now the answer is, please remember, second most common is Lewy body disease. Please remember, it is Lewy body. Third you can say as vascular if they ask you most common, vascular dementia. Okay. Now Alzheimer's disease is a cortical dementia. Remember, Alzheimer's disease is a cortical dementia. Even pig disease, even pig disease, this was asked in fact in a NICT exam. In one of the previous year question you will find this. So if you know another name of pig disease, you will be able to say that it is cortical or subcortical. What is another name of pig disease? Anybody? It is also known as frontotemporal dementia. So see the name is only telling you frontotemporal dementia. The name is telling us that the frontal and the temporal lobes are involved. So it is also a cortical dementia. Right, now give me some examples. So some of you were mentioning Parkinson dementia due to Parkinson disease. Yes, that can also cause dementia. So Parkinson disease dementia. in Huntington's disease, multiple sclerosis, Wilson's disease, even PSP, progressive supranuclear palsy, and so many other. They are also causes of dementia, and usually they cause subcortical dementia. Now in Parkinson disease, if I ask you, usually what are the symptoms we see? Very good. In Parkinson disease, usually you will read it in medicine, you must have read it in medicine, in neurology. Patient comes to us with tremors, there is rigidity, there is bradykinesia, a lot of motor abnormalities. Even in Huntington's disease, in Wilson's, all these you will find a lot of motor abnormalities. So can I say in the initial stages, motor system may be normal here, but it may be abnormal here. Again, sometimes if they want to frame some newer questions, they may ask like this. A patient comes to us with cognitive impairment and the patient has a lot of abnormalities in the motor system. There may be abnormal movements, jerky movements may be there in the initial part of the treatment, in the illness. So which dementia you are thinking? So maybe in the option only one subcortical example they mentioned. So try to answer it like this. So please remember this. I hope this is very good. I hope this is clear to everyone. So two important classifications we discussed. Now let's see one question. Again, this is one question which was repeated in NEET PG also and even in FMGE also. A 75-year-old female having difficulties in doing activities of daily routine. So here they are telling you that there is cognitive impairment. Patient is not able to perform daily activities. Patient is also having visual hallucinations. And there are some movement abnormalities like bradykinesia, tremors. And in the pathology they have mentioned Lewy bodies are found. Can you tell me the diagnosis? Now the question was a bit different, the options were a bit different, but we'll come to that also. But first, if I ask you give me one diagnosis. One of the diagnoses which is coming to your mind is Lewy body dementia, isn't it? We'll talk about Lewy body dementia, very important dementia. In fact, now it is the second most common cause of dementia, especially in elderly. So Lewy body dementia, will discuss all these features, and even in pathology, Lewy bodies are found. Very good. Can you tell me one more condition which also have similar feature? That is, yes, Parkinson's disease. Very good. So in the question which they asked in NEET PG and FMG, there Lewy body disease was not mentioned. So one of the differential diagnoses of LBD is Parkinson's disease. We'll come to this again. Let's first talk about some core features. Now there is some update in this now. Please remember this. That may come as a new question now for the exam. There are some changes in the criteria. Okay, in the latest edition there are some changes. So core features, earlier we used to read 3, but now there is one more which is shifted in the core features. So there are 4 core features which we will discuss of Lewy body dementia. In fact, Lewy body dementia or vascular dementia also, if you ask me, sir, it is cortical or is it subcortical, usually they may have mixed features. So from this also you can remember. So Lewy body dementia may have a mixed feature, cortical symptoms also and subcortical. So when the cortex is involved, we will get cognitive impairment. So the first symptom is there is cognitive impairment, fluctuating cognition. So there is cognitive impairment and that is fluctuating. That means it is changing over time. So family members may notice it is more in the morning, less in the evening, afternoon, then again increased in the evening. So cognitive impairment is there. Can you appreciate visual hallucination we discussed are more common in, in organic mental disorder, visual hallucinations are more common. See, it is there in the core criteria. I told you it is mixed. That means even the subcortex is involved. So when subcortex is involved, remember motor features of Parkinsonism like tremors, rigidity, bradykinesia, isn't it? So all those features which were mentioned in the question, they are present. Now remember this point may come as a new question. Remember this, that REM, sleep behavior disorder, REM sleep behavior disorder may also be seen. They are now also included in the core feature. So please remember this. So REM in sleep disorders, you will read, we have discussed in main videos also, there are NREM disorders, REM disorders. So REM sleep disorders may be seen, sleep behavior disorder may be seen in Lewy body dementia. This is also now included as a core feature. So please remember this important point. Okay, just like they ask Capgras syndrome, next time they may ask this. Okay. Now also there are some supportive features such as severe neuroleptic. Neuroleptic means antipsychotic sensitivity. So they may develop antipsychotic induced EPS. We'll talk about EPS today. So in this patient is having visual hallucination, you may think of giving antipsychotic, but after giving antipsychotic, patient may develop EPS, extrapyramidal symptoms. So please remember they are again sensitive to the antipsychotic induced EPS. So please be very careful. We give in low doses antipsychotic if you have to give Also, if we have to give antipsychotic, we give antipsychotic which has less potential of EPS. Then they may also cause, again I am highlighting some important points, they may be having, patient may be having repeated syncopal attacks, they may fall, there may be transient loss of consciousness. Remember, severe autonomic dysfunctions, fluctuation in blood pressure, pulse rate, that may also be seen. Hyposomnia may be there, sleep problems, visual hallucination, we discussed in the core feature, other hallucinations such as auditory, tactile, they may also be seen. Now, remember one important delusion we discussed, delusion of persecution can be seen, but can you appreciate here Capgras syndrome may also be seen. So, I am trying to highlight some potential questions so that you remember a patient coming to you with these features, which dementia we are thinking of. Please remember this. One already they have asked, then depression, other symptom may also be seen. So, these are supportive features. Please see the slide again. These are the core features and these are the supportive features. Now, in the pathology, can you tell me what will be the findings in pathology? In pathology, what we will find, anybody? In pathology, can you tell me what is this? There is a central core. If you appreciate, there is a central core, okay, that is surrounded by a halo. What is this? What is this finding, anybody? These are what is known as Lewy body, alpha synuclein, made up of alpha synuclein. In fact, this was shown in the in the question in the FMG exam. That FMG exam wala question, they had given this image and they had given the picture of Parkinson disease and they had asked you what is this, identify this image. So their answer was these are Lewy bodies. Okay, so one important point, along with Lewy body dementia, they may also be seen in Parkinson's disease. So let's come back, very good. Let's come back to that question. Now, can you appreciate, so here we are saying that all these features are present in both, all these features, that is cognitive impairment, then visual hallucinations, even these motor abnormalities can occur in both, and even Lewy bodies are found in both. Okay, but what if they give both the options? Then can you tell me how will you differentiate? Again, a very important point you can remember. How will you differentiate if both are given in the option? Go back to that classification we discussed, cortical and subcortical, where we have placed Parkinson disease. I told you this point, na? Parkinson disease is a subcortical dementia. So here you will find a lot of motor symptoms initially. So usually clinically you will see motor symptoms, and in the research criteria we say after the start of motor symptom 1 year later cognitive symptoms they occur. So when the motor symptoms are initially, then I am thinking of Parkinson disease. While in Lewy body dementia, remember cognitive symptoms are present, and along with this motor symptoms may be present in the beginning or may occur afterwards. So very important point. So if some newer questions may be asked, they may be asked like this, because they are asking questions on Lewy body dementia, Parkinson disease. I hope this is clear to everyone, very important. Okay, I hope this is clear, right? Very good. Now let's talk about, so we have talked about some points about dementia. Now let's talk about the management. Now again, when we talk about management, I always say, when you will be reading psychiatry, try always to correlate etiology and the mechanism of action of drugs. Drugs के mechanism को हमेशा etiology से compare करो तो आपको कोई confusion नहीं होगी. Now let's take an example of Alzheimer's disease. Now Alzheimer's disease, we discussed, it's the most common, it's a cortical type of dementia. In Alzheimer's disease, we know there is decrease in acetylcholine, the acetylcholine is reduced, glutamate increases, and also there are A beta deposits. Can you tell me what are these A beta deposits known as? What are these A beta deposits? Amyloid plaques. Amyloid plaques, okay. Amyloid plaques or senile plaques or neurotic plaques, they may be seen, okay. Even when you will read pathology, you will read even neurofibrillary tangles, they may also be seen in Alzheimer's disease. So let's try to correlate. So in the etiology, we know acetylcholine is reduced. So we use a drug that is cholinesterase inhibitors. Very good. We use a drug cholinesterase inhibitor which increases acetylcholine. So can I correlate this with the etiology? In the etiology it is decreasing, I am increasing it with acetylcholinesterase inhibitors. Then we discussed that glutamate is increased. So we are using NMDA, it's a glutamate receptor. We are using a NMDA receptor antagonist. And now we have some new drugs, we will talk about these new drugs. So some new points also I will discuss. So some monoclonal antibodies we have. So monoclonal antibodies, they bind to these A beta deposits and they help in the clearance. Very important, 3 new drugs we will discuss under this category. I hope it is clear, yes. So let's talk about some drugs such as tacrin. So cholinesterase inhibitors, remember tacrin, which is not used nowadays much because of one important side effect. Can you tell me what side effect we are talking about? That is hepatotoxicity. Okay, hepatotoxic. So it is hepatotoxic, right? So remember, because of hepatotoxicity, it may not be used much nowadays. Okay. Now, there are some other drugs you can remember: donepezil, rivastigmine and galantamine. Now, this question was asked in INI-CT exam, that a patient on cholinesterase inhibitor, he developed GI symptoms. Okay, so there were GI symptoms, side effects occurred. Which drug, which out of these only, which drug you can use? So remember, they're trying to ask you, is there any drug which can be given through other route? Remember, yes, drugs like rivastigmine, they can be given through transdermal patch. So there is transdermal patch available for rivastigmine. Now there is one new update. Remember, now we have one oral drug, new drug which is approved for dementia, benzgalantamine. So this is again because of GI side effects. Because of GI side effects, now we have one more new drug. You can update this. So please remember, I'll also talk about some newer updates. Benzgalantamine, it's a oral drug. It's a oral drug. Again, it's a oral drug which has again very less or very minimal GI side effects. So to decrease the side effects of gastrointestinal side effects, benzgalantamine is there now. Okay, so please remember this. This question has been asked previously. They may also ask you which is the new oral drug now which has less GI side effect. That is benzgalantamine. I hope this is clear to everyone. Very good. Yes. Now, one important drug under the category of NMDA antagonist, can you tell me? That is mementin. Okay, mementin. It is usually used in moderate to severe cases, and sometimes we can also combine mementin with cholinesterase inhibitor like donepezil. So even combination can be used. Now, in India up till now we have only these two drugs, and let me tell you, these drugs don't cure dementia. They slow down the disease process. But now we have some newer drugs. Let's talk about, that is A beta deposits we discussed. So monoclonal antibodies, they are used for mild Alzheimer disease. So these drugs, they are given through IV infusion, through IV route they are given, and they basically bind to these A beta deposits and help in the clearance. So there are three important drugs. Again, just remember this trick. I'll give you one trick to remember. So see the name Alzheimer disease and you will able to remember the name Alzheimer disease. So from the name itself you can remember. One is starting with A, that is aducanumab. One is aducanumab. Another is starting with L, that is lecanemab. One is starting with L, that is lecanemab, and another. So remember this L, and one is with D, that is donanemab, and one is donanemab. So please remember these names: aducanumab, lecanemab, donanemab. Will you be able to remember? Yes. So just see Alzheimer disease, they are used because we know A beta deposits are there in Alzheimer's disease. These other drugs may be used in other dementias, but these are drugs used for mild cases of Alzheimer disease. Okay, I hope it is clear to everyone. So in this one slide we have tried to discuss some important treatment of dementia, right? Now let's see one interesting question. Now this is again a PYQ and we have talked about this concept. Just try to see. Again I am saying try to focus on the language of the question, because sometimes the concepts are not very difficult, the language may be difficult. Which of the following is not suggestive of a medical cause of mental illness? Just let's now, here we will take a vote. I want all of you to answer, doesn't matter if it's wrong, so what? But I want all of you to answer. Which of the following is not suggestive of a medical cause of mental illness? Very good. So some of you are saying it is A, elderly age, B is acute onset, C is loss of consciousness, and D is auditory hallucination. Very good. Others, I want all of you to answer. Very good. Some of you are also saying it is D. Very good. Now please try to first appreciate what is the question. They are asking you, first tell me what does this mean? Medical cause of mental illness. If a mental illness is having some physical cause, so we call it as organic disorder, isn't it? Organic mental disorder, isn't it? Now read the question again. Which of the following is not suggestive of organic mental disorder? Now I am sure now you can come to the answer. But please remember, we discussed dementia, delirium, they are more common in elderly. So this is suggestive. A person is developing a mental illness there may be a medical cause, especially in elderly age. Acute onset, we discussed, delirium has an acute onset. Sudden onset may tell us maybe there is some medical issue. Consciousness impairment again is telling me that there is some medical issue maybe there. Like in delirium we discussed, consciousness is impaired. Please remember, it is not auditory hallucination. We have been talking about this, that visual hallucinations are more suggestive of organicity, isn't it? So this is the answer. So that simple point again, but they have highlighted like this. So please be very careful. The answer is option D. I hope this is clear to everyone now. So please be very careful. So these were some important points we discussed about delirium, dementia. Now let's talk about, what some psychotic disorders. So let's come back to this question. A 40-year-old male patient is brought to the psychiatrist with an illness of 10 years. So illness is 10 years. Family members report that when any happy event, sad event come, he shows no emotion. So we have identified this as flat affect, isn't it? We have identified this flat affect. He also doubts that his wife is not his wife but a neighbor in disguise and doesn't get confused. So we have discussed it's a delusion, that is Capgras syndrome, it's a delusion. He also a report of hearing voices that neighbor are talking about him, not heard by other, that is he is also having auditory hallucination. Can you tell me what is the diagnosis here? Again in psychiatry I am trying to tell you how to identify the symptoms in the question, and one more important keyword in psychiatry questions especially is the duration. Many times you will see that duration, you change the duration, the diagnosis will change. So here the duration again they have given, yes, it is schizophrenia. Very good. So let's talk about schizophrenia. Again I'll talk about the symptoms of schizophrenia, and again I give this very simple mnemonic. If you have seen this movie, a very famous old movie of Akshay Kumar, Shilpa Shetty, Sunil Shetty's movie. Again in the movie nobody had schizophrenia, so don't worry if you have not watched the movie, but don't watch it now, you can watch it after the exam. But if you just remember the name Dhadkan, so just if you remember the name Dhadkan, you will be able to remember the symptoms. Yes, so remember D, so just see the name Dhadkan, okay, just see the name. Yes, so D for delusion, all of us know. Now please see, have I mentioned which delusion here? So any delusion can occur in schizophrenia. Again any hallucination can occur, but most common if they ask it is auditory. Disorganized speech, can you appreciate all those formal thought disorders which we discussed, such as loosening of association, tangentiality, derailment, neologism, they may be seen here. Now let's also talk about catatonic symptoms and negative symptoms. Now let's talk about that, then I'll come to the diagnosis. Okay, so now let's talk about what are catatonic symptoms, what are negative symptoms. Okay, first three we have already covered, isn't it? So when we understand the basics well, you are able to now understand all these points. Now let's come to first negative symptoms. Now negative symptoms, patient may have these negative symptoms such as anhedonia. What is anhedonia? Anhedonia means there is decreased interest. So patient says, sir, earlier things which I used to enjoy, that interest has gone in those things. It can be seen even in depression. Then avolition. But what is volition? Volition means willpower. So avolition means that there is a decrease in the will, decrease in motivation. Family member says, sir, it does not show any will to do anything. Can you appreciate, we discussed neologism. What was neologism? Very good. Neo means new, logism, logos means word. So what is alogia? There is a decrease in the speech. Family member says, sir, he speaks very less. We ask a question for 10 minutes, he answers with just 1 or 2 words, speaks very less. Remember we discussed flat affect or blunt affect. So please remember this, affect, blunting or flat affect, right? So there is a decrease in the expression of emotions. Like in this case, patient, in fact this question was asked, we discussed even in LRR, this question was asked in the recent FMGE exam, we'll talk about that. So there is decrease in the emotional expression. And lastly also remember asociality, that is, so please remember, asocial and antisocial are different. Asocial means less social, antisocial means against society. So in antisocial personality disorder, patient is doing behaviors against society. Asocial means person is decrease in the socialization. Family members say that he socializes very less, does not meet people. So these are some negative symptoms which can be seen in schizophrenia. I hope please remember these terms. Sometimes simple questions are asked. So this was the question which was asked. Which of the following symptom does the term affective flattening imply? What symptom is it? I am sure now you can tell me. Affective means, is it a mood symptom? No, it is not a mood symptom. Is it a positive symptom? We'll discuss. No, delusions and hallucinations, Delusions and hallucination, these are positive symptoms of schizophrenia. It is not a cognitive impairment, no. It is, the answer, right answer here is, it is a negative symptom. Very good. The answer is, it is a negative symptom. I hope it is clear to everyone. So we have covered delusion, hallucination, disorganized speech, negative symptom. Now let's talk about a very important topic, that is catatonia or catatonic symptoms. Now this again is very important. You will see many questions in a PYQ related with catatonia. Now catatonia, basically patient is having a group of motor signs and symptoms. So patient में motor sign symptoms है. And please remember, I am discussing catatonia in schizophrenia, but catatonic symptoms can also be seen in other conditions, even in mood disorders. In fact, they are more common in mood disorders than even in schizophrenia. But let's discuss here. So let's discuss these symptoms. I have clubbed these symptoms together so that you understand. Many times questions will be asked from these terms only. So let's talk about stupor. Stupor is what? There is akinesia. Patient is not showing much movement, and there is mutism. Patient is also not talking much. So sometimes even in catatonia, patient may be in a stupor state. Patient is just lying down, not moving much, not talking much. Sometimes opposite may also occur. That means patient is in a very excited state. His psychomotor activity, PMA. In stupor, the psyche means mind, motor means body. Psychomotor activity was reduced in stupor, while it may be increased in excitement. Patient is running around, removing cannula, removing catheter in an excited state. Some patient may also have mutism. Mutism, again, very simple to remember. When you watch a television, you can mute the TV. So the screen is moving, but you cannot hear anything, as if we have muted the patient. So patient is doing activities, but he is not saying, very little speech, mutism. Now let's discuss what is waxy flexibility. Sometimes you will see this term in the question, and you will see some questions, even in PrepLadder QBank, you will see questions on this. So let's try to understand what is waxy flexibility. As if person is flexible like a wax candle. For example, if this is a wax candle, if I try to mold this, there is initial resistance, and after that I can mold the way I want. Similarly, suppose you take up patient hand. Suppose I have taken the hand of the patient. So I am finding initial resistance, and after that I have molded the way I want it. So can I say it is waxy flexibility? Yes. So there in waxy flexibility, there is some initial resistance. There is some initial resistance. Very good. Now let's talk about negativism. Let's talk about two more terms together. Negativism, as if, very simple to remember. Just see the name. Negativism means as if patient, is having a very negative attitude towards the examiner. So whatever I am saying, he is doing the opposite, or there is no response. So in the MCQ, they may just tell you, you ask a patient to come forward, he goes backward. You tell the patient, आगे आओ, वो पीछे जा रहे हैं. He is doing opposite, so this is negativism. While automatic obedience, can you appreciate here? Now the patient is extremely cooperative, extreme cooperation patient is showing. Automatically is obedient. Whatever I tell the patient, he will do, even if it is harmful. Suppose I tell the patient, I am holding a needle and I will prick your tongue with this needle. I have given this instruction. I tell the patient to pull out the tongue. He will pull out the tongue. Even if I slightly prick his tongue, again he will pull out. So this is automatic obedience. Now let's discuss the next two terms together. Again see, both these terms means very similar. Both of them mean patient is doing some repetitive, patient is having some repetitive odd movements. So patient is doing some repeated odd movements. Then what is the difference? Please see the name. Again, I always say see the name. So the name is telling you mannerism means the patient is, these movements are having some purpose, some manner. So these are purposeful. These are purposeful movement. For example, a patient is doing this movement, but he is repeating it again and again. Can I say, this is a salute movement, but he is doing repeatedly again and again. So this is mannerism. While stereotypic movements, these are non-purposeful movement. For example, movement like this, no purpose. So this is stereotypy. Okay, please remember. Now, very good. Now let's see what is echolalia and echopraxia. Again, just see the name and you will understand the concept. Echo means to repeat. Lalia means word. So patient is repeating, mimicking the words. I ask the patient, what is your name? He says, what is your name? What do you do? What do you do? So whatever I am saying, he is repeating it. This is echolalia. Now you will tell me what is echopraxia. Just see the name. Echo or echo means to repeat. Can you appreciate we discussed apraxia? Apraxia means that there was problem in fine movement na. So praxia means movement, ecopraxia means here the patient is repeating the movements of the examiner. For example, you are writing something with a pen and paper in front of the patient. Patient has no pen and paper, but he is also doing the same movement. So this is ecopraxia. Let's discuss next two terms. Grimacing means patient is maintaining a odd facial features. You know, nowadays when you take a selfie, what do? You pout. And if you maintain that pout for a long time, it is grimacing. Next is ambitendency. See this, ambi means not able to decide, tendency means movement. So not able to decide a movement, that is ambitendency. Okay, for example, there is a pen on the table, patient's hands go forward, then backward, then forward, then backward. He is not able to decide, should I pick it or should I not pick it up. So this is ambitendency. Is it clear? Now last two we'll also discuss. Very good. Yes, all of you are answering correctly. Now see this, patient is maintaining such odd postures. So there are two more terms which you can remember. One is catalepsy. Remember, there is something known as cataplexy. So कैसे याद करोगे? Cataplexy is seen in narcolepsy. Narcolepsy is a sleep disorder. So narcolepsy में we don't get catalepsy, we get the opposite, cataplexy. So catalepsy a catatonic symptom and posturing. Both of them means that patient is maintaining some odd posture like this. You know, sometimes patient is standing like this, standing on one foot for entire day. So patient is having such odd posture. So catalepsy is when somebody has made the patient stand like this and now is maintaining, then it is catalepsy. But if the patient himself came into this posture and now is maintaining it, then that means it is active. So it is posturing. I hope now you can also differentiate between catalepsy and waxy flexibility. Again, you will see when you will see the Q banks. So this doubt also comes, you know, in the our PrepLadder also you will see these questions. So in waxy flexibility, remember how to differentiate. There is initial resistance. While in catalepsy, there is no resistance and patient is maintaining it for a long time. So this is catalepsy. I hope this is clear to everyone. Now I'll come back to this. So we have understood all these 5 symptoms. Let's understand how to make a diagnosis of schizophrenia. So according to DSM-5, remember out of these 5, 2 or more symptoms should be present in the patient. Okay. And at least, there is one catch, at least one symptom should be from the first 3. That is why I want you to remember the sequence. That is why I gave you a mnemonic. And the symptom duration according to DSM-5 is 6 months. Then we make a diagnosis of schizophrenia. Less than 6 months, you will call it as, according to DSM-5, acute psychosis. Okay. So based on the duration. So here in the question, the patient was having for 10 years. So diagnosis was schizophrenia. While according to ICD-11, what is the duration? Can anybody tell me? What is the duration according to ICD-11 for schizophrenia? It is 1 month. For schizophrenia in ICD-11 again, very good. Is it clear to everyone the duration? For in ICD-11 it is 1 month. Again, mostly for the question you can choose this, but again if they have specifically asked you ICD-11, then you can go with that also. And if the symptoms are less, the symptoms are similar to schizophrenia, duration is less, then we will call it as acute psychosis. Okay, I hope it is clear to everyone. Now, we were talking about catatonia. Again, we'll come to the treatment of schizophrenia also. We were talking about catatonia. Now, see this. A patient comes to us with voluntary purposeless movements. He is doing some purposeless movement. There are stereotypies. He is having negativism and he is also having waxy flexibility. Can I say patient is having catatonic symptoms? Catatonic symptom, we'll discuss. If patient has 3 or more symptoms, it is catatonic symptoms. What is the treatment? Can anybody tell me what is the appropriate treatment? Okay. Yes, very good. Is it C? Is it C? That is an important point. Please remember, for the management of schizophrenia, it's a psychotic illness, we'll choose antipsychotic. But for catatonic symptom, that is why I'm discussing. But for catatonic symptom, you will see, patient here is having catatonia, na? Remember, very good. The treatment here is, it is lorazepam. Very good. If 3 or more symptoms are there, we have made a diagnosis of catatonia. Remember, in the treatment of catatonia, you give lorazepam. Usually, we give it, parenterally like IV, even orally you can give, and you will see drastic improvement. drastic improvement in the symptoms within few minutes. So, first line treatment is lorazepam. If that is not working, or if they ask you best, then you can use ECT. Very good. What is ECT? Electroconvulsive. Very good. Convulsive therapy. ECT can also be used. What is electroconvulsive? Electric means we are giving electric current and we are producing convulsion. So, ECT can be used. And also remember, nowadays in India, when we use ECT, we use modified ECT. Modified ECT means that we give it with general anesthesia and muscle relaxants. Okay. So, another important point I have just discussed. So, ECT nowadays in India, in MHC, Mental Health Care Act, the direct ECT procedure is prohibited. We give it with general anesthesia and muscle relaxant. Okay. So, remember, for catatonic symptoms, so that was the question asked. Sometimes they ask only the symptoms. So, I hope this is clear to everyone. Very good. Yes. Yes, we give, sometimes when you are doubtful whether patient is having catatonia or not, we give lorazepam challenge test. Very good. Lorazepam, we give low dose of lorazepam. If the patient shows improvement, it is suggestive that it may be catatonic symptoms. Very good. Okay. Now, let's talk about the antipsychotics. Now, when we discuss antipsychotic, this is an important, table I am discussing. Many times you will see nowadays questions being asked on the neurotransmitters, they will ask you about the etiology. Now, when we talk about schizophrenia, in fact, when we talk about the psychotic illnesses, we'll discuss various dopamine pathways in the brain. Now, two dopamine pathways, one is mesolimbic and another is mesocortical pathway. They are related with symptoms. So, can you appreciate from the name? Meso means midbrain. Meso means midbrain. Limbic means they are going to the limbic system, such as nucleus accumbens. So, from the midbrain they are going to the limbic system. It is seen that in this pathway in schizophrenia, dopamine is increased. Okay, and that leads to what is known as positive symptoms of schizophrenia, such as delusions, hallucinations. Okay, while in the mesocortical, again meso means midbrain, cortical means cortex. In this pathway it is seen that there is a decrease of dopamine in this pathway in schizophrenia, and that leads to what symptoms? That leads to negative symptoms. Okay, in fact earlier, there was earlier a hypothesis known as dopamine hypothesis, which stated that in schizophrenia there is increase in dopamine, but now our understanding is improved. We know now there are various other pathways, and in one pathway it is increased and another it is decreased. Okay, so two dopamine pathways you can remember. In fact, there are other neurotransmitters also which are implicated. We'll discuss. Okay, so one important neurotransmitter is dopamine. Okay, so can I say, this path hypothesis is saying that dopamine increase ho raha hai schizophrenia mein. So what drug can I give to decrease it? So if I give dopamine antagonist, it may improve schizophrenia. In fact, we'll discuss that antipsychotics which we give, what they do, they are dopamine antagonists. So very important, we'll talk about this. So antipsychotics, they are dopamine antagonists. We'll discuss various antipsychotics. They are dopamine, especially D2 antagonist, especially the first generation. Okay, so can you remember? So you will always try to correlate the mechanism of action of drug with the etiology. Questions solve ho jayenge काफी बार. Okay, you will see this. I hope this is clear. Very good. Now also let's talk about two other pathways of dopamine. So we are giving patients dopamine D2 antagonist. Now there are other dopamine pathways also. One is nigrostriatal pathway and another is tuberoinfundibular pathway. So जब हम antipsychotic we are giving, so dopamine will block, the antipsychotics will block dopamine in these receptors also. So let's try to see what side effects can occur. So let's come to this. In medicine you will read this nigrostriatal pathway. So substantia nigra, it starts and goes to the striatum. In fact, in Parkinson disease, what is the treatment we give? We give drugs like levodopa. Why? Because there is a decrease in dopamine in this pathway. So there is a decrease in dopamine in this pathway in Parkinson disease, and can I say because of that it is leading to motor symptoms? Is it clear to everyone? Tell me if this point is clear to everyone. Now I am giving a patient antipsychotic. The antipsychotic will block the dopamine receptors, so this will block in this pathway also. So when dopamine is reduced in this pathway, can I say it will cause EPS? So many of these, EPS which we will discuss, extrapyramidal symptoms such as acute dystonia like this, sudden twisting of neck. So these, may occur because of decrease of dopamine in this pathway. Is this point clear to everyone? I hope this is clear to everyone. Let me know if this point is clear. Very good. So can you appreciate, one of the important points of these EPS, because they are decreasing dopamine in this pathway. Now let's also talk about one more pathway, that is tuberoinfundibular pathway. This pathway is going from the hypothalamus to the pituitary. Now in physiology you will read that in this pathway, dopamine and prolactin, they have a inverse relation. Again, this is also a question, which sometimes are asked. Okay, so what will happen? So if I am giving antipsychotic to a patient, dopamine is reduced in this pathway. What will happen to prolactin? Remember, there is increase in the prolactin level, hyperprolactinemia. And this hyperprolactinemia may cause decrease in the libido in males and females, and in females it may cause galactorrhea, that is milk secretion, amenorrhea. Usually, increase in prolactin occurs after delivery. So there is amenorrhea, there is galactorrhea, but here a young female in reproductive age group taking antipsychotic comes with galactorrhea and amenorrhea. She is not pregnant, not delivered, because of hyperprolactinemia it may occur. So please remember this as well. I hope this is clear to everyone. Right, now let's talk about some important EPS. Many times you will see questions on EPS being asked. So see this question. A patient diagnosed with schizophrenia was taking medicine trifluopromazine, which is a first generation antipsychotic, and he developed Parkinsonism-like symptoms. He developed tremors, rigidity, bradykinesia. So this is, we'll discuss, this is pseudo-Parkinsonism, okay, or drug-induced Parkinsonism. What is the treatment? So remember, yes, very good, I'm very happy, yes, all of you are marking correctly, yes, trihexyphenidyl, which is a anticholinergic drug. Very good. Let's talk about some important EPS. Again, this is a very important table. Now again, I just discussed, one of the question which was asked, and you will see many questions being asked from this. So let's talk about some important EPS, and I will give you a trick to remember it with this mnemonic DP at night. So in medical colleges there is DP, dance party at night. So with this we will remember all the important EPS. So remember D for dystonia. Remember dystonia, there is contraction of a group of muscle. Acute means there is sudden contraction of a group of muscle. So patient after receiving antipsychotic, in fact it is one of the earliest EPS to occur, especially sometime when you give IV or IM, maybe within minutes or hours patient may develop this. So patient may come, my eyes are uprolled upwards, there is oculogyric crisis, or there is torticollis, sudden twisting of the neck. Patient may even have laryngospasm. Sometimes again it's an emergency, patient has developed laryngospasm. What is the treatment? Remember, yes, anticholinergic drugs such as promethazine, even benztropine, these can be used. Then patient on antipsychotic developed tremors, rigidity, very good. Bradykinesia, very good. Phenargan, yes, it has promethazine, very good. You will see in emergency this is given, very good. So this is the question we discussed, tremors, rigidity, bradykinesia. Again here treatment is anticholinergic drugs such as trihexyphenidyl. Here we can give even oral. Usually here you may give the drug parenterally because acute dystonia is very distressing for the patient. Okay, patient may come in emergency with these complaints. Okay, so A for dystonia we discussed, P for Parkinsonism. Then next A we'll discuss, that is akathisia. Now akathisia, in fact remember it is the most common. If they ask you which is the most common EPS, it is akathisia. Now akathisia basically means restlessness. So patient is very restless. Patient will say subjectively, sir, I am feeling very restless from inside, sir mujhe घबराहट हो रही है, I am having very, I am very restless. And when you see the patient also, he is continuously moving, not able to stay still. So both subjectively and objectively he is appearing restless. So what you are suspecting, it is akathisia. Again, what is the treatment? Remember, for akathisia, if you are asked one drug, you can go with beta blocker like propranolol. So we discussed DP at. T for tardive dyskinesia. Tardive means something which is long term, occurring after long term treatment. Dyskinesia means some abnormal movements. So patient, in the history they will tell you for months patient is on some medication and he has developed lip smacking or chewing movements like this, oral movements, or patient is having tongue protrusions, or there is piano like movements on the hands. So you're thinking of tardive dyskinesia, and the drug which we use is drugs like valbenazine, tetrabenazine. These are VMAT2 inhibitors, vesicular monoamine transporter 2 inhibitors. Last is at night, N for very important, neuroleptic malignant syndrome. Again, if something is malignant, that means that it is life-threatening. NMS, patient may come, again it is a life-threatening condition. So here patient has developed high temperature, increase in the CPK. What is CPK? Creatine phosphokinase level. Muscle rigidity is there, sweating is there, tachycardia is there. Okay, patient may come to us with confusion. There is abnormality in the blood pressure. So again, what will you do? Please remember, first step is you will stop the drug. Stop the antipsychotic, stop the drug, and if they ask you drug of choice for the management, dantrolene. Then we can also give dopamine agonists like amantadine and bromocriptine. So try to appreciate these clinical scenarios. In the history they will tell you patient is on antipsychotic. Think of these abnormalities. I hope this is clear to everyone. Very good. Yes. Is it clear to everyone? Now see this again, recently also this question was asked. A patient with sudden spasm of muscle, there is sudden contraction of group of muscle due to antipsychotic. So what are you thinking? Which EPS are you thinking of in this situation? Can anybody tell me? So here you are suspecting it is acute dystonia. There is acute dystonia. So tell me, what will you do? What is the answer? Here you will give IV benztropine. Very good. So you will give IV benztropine. Now let's talk about some antipsychotics. So we have first generation and we have second generation antipsychotics. So mechanism of action, very good. So mechanism of action, yes. So the answer here is yes, C, benztropine. It is acute dystonia. Very good. Now we have first generation antipsychotic, that is typical, and we have second generation antipsychotic, that is atypical. Now what is the mechanism? First generation is D2 antagonist, while second generation is D2 as well as 5-HT2A antagonist. How to remember? So even serotonin, remember, is increased in schizophrenia. So here we are using drug that is serotonin antagonist. So remember both are 2, and A for, you can remember A for atypical. Okay. So atypical, why? Because it has some other mechanism of action as well. Now EPS occurs because of D2 antagonism. So tell me which has more EPS, first generation or second generation? Remember, first generation usually has more EPS, second generation has less EPS. So please remember this, first generation has more EPS, second generation usually has less EPS. Now what are metabolic side effects? Metabolic side effects are side effects such as weight gain, hypertension, very good, such as dyslipidemia. Okay, patient may develop these, cardiovascular disease. So these are metabolic side effects. How to remember? They occur, please remember, end may there is metabolic na. So they are occurring because of 5-HT2C antagonism. This question was asked in the INI-CT exam. So once a question is asked, please be very careful, it can be repeated in any exam. So metabolic weight gain, it was asked, occurs because of 5-HT2C antagonism. So again, metabolic side effects, serotonin is blocked by which? You can remember it like this, by second generation. So metabolic side effects are more with second generation and they are less with first generation. In fact, this question was asked twice recently in the FMGE exam also. So they are again and again asking questions on side effects. Please let me know if this slide is clear. So we'll talk about some first generation drugs. One is haloperidol. Haloperidol is one of the first generation drugs and it has maximum EPS. One of the first generation with maximum EPS is haloperidol. Let's discuss some more. One is chlorpromazine. So one is chlorpromazine. Okay, now chlorpromazine is the first generation. We know mechanism of action, it is D2 antagonist, but it also blocks some other receptors. So it can also block alpha receptors. So if it blocks alpha receptors, it can cause side effect like hypotension. It can cause hypotension. Also remember what is H. H is histaminic. It can also block histaminic receptor, it can cause sedation, and also remember because of antihistaminic effect, one of the side effects can also cause is weight gain. In fact, this question was asked, it's a tricky question, I will come to this. Even chlorpromazine can cause weight gain. And if it blocks M, muscarinic receptors, it can cause antimuscarinic anticholinergic side effects. Okay, anticholinergic side effects such as dry mouth, blurring of vision, urinary fecal retention. These side effects can occur. Okay. One important ocular side effect, very good. I want you to remember. C for chlorpromazine, remember C for corneal and lenticular deposits. So there may be deposits on the cornea and lens, posterior cornea, anterior lens. It can be caused by chlorpromazine. Okay, so sometimes they may integrate, ophthal with psychiatry. Remember, chlorpromazine can cause these findings in ophthal. One more drug we can remember, thioridazine. So remember, yes, even C for cholestatic jaundice, that also it can cause. Yes, very good. R is coming. Again, remember 3 R's. Again, one important ophthal finding which you can remember here is retinal pigmentation. Remember, retinal pigmentation. Very good. Then few more we can remember. One more R for rise, increase in the QTC, and even retrograde ejaculation and decrease in libido. Sexual side effects can also occur. We discussed first generation antipsychotics. Usually they have high EPS, but one of the first generation which has least EPS, remember, it is thioridazine. So thioridazine is a first generation, but it has least EPS. So these are some points we have talked about, few of the first generation antipsychotic. Let's now discuss, some points about second generation. In second generation, you can remember olanzapine. Olanzapine, again, it has one of the side effects like weight gain. Remember, weight gain is one of the side effects. Okay, we'll talk about even risperidone. Risperidone, again, we discussed that usually the second generation have less EPS, but it is one of the drugs which has a high EPS. Okay, so remember, I'll talk about some more drugs, but let me come to one more important drug, which is clozapine. Now, clozapine is a second generation drug, and you will see many PYQs being asked. Very good, yes, Ito, it's correct. Clozapine. Let's discuss clozapine. It's a second generation antipsychotic, but there are some unique points about clozapine. Now, clozapine, we have discussed usually all the antipsychotic, the dopamine receptor they are acting on is D2. But clozapine is blocking D4 more than D2. EPS is occurring because of D2 blockage. So it has one of the drugs, it has one of the second generation with least EPS. Now also remember, it is the antipsychotic which has anti-suicidal property. It decreases suicidal ideation. If they ask you mood stabilizer, which has anti-suicidal property, then what will you choose? Tell me, what will be the answer? Yes. If they ask you mood stabilizer with anti-suicidal property, then we will choose lithium. Antipsychotic with anti-suicidal property, it is clozapine. So please remember, clozapine is used, very good. Clozapine is used for one important condition, that is treatment-resistant schizophrenia, which was asked. This question was asked in the NEET PG exam. What is treatment-resistant schizophrenia? The name is telling us that the patient is having no response. There is no response to at least 2 antipsychotics. So patient, let us say we have given olanzapine, there is no response. There is haloperidol, we have given no response. Then, so there is no response to at least 2 antipsychotic, then you can think of giving clozapine. Okay. Now, coming to the side effect, most common side effect is sedation. One of the reasons is H1 blockage. It can also cause cyalluria. Okay, that is the patient is having hypersalivation, hypotension, weight gain. In fact, this is one of the drugs with maximum weight gain. So 2 drugs very notorious to cause weight gain, clozapine and olanzapine. It can also cause constipation because of anticholinergic side effects. So these are some common side effects. Let's discuss some serious side effects with clozapine. Now you can remember the serious side effect with the mnemonic SAM. What is S? Can anybody tell me? Yes, very good. S for seizures. Patient on clozapine develops seizure. What you can do? You can treat it with anti-epileptic drug. So you can give anti-epileptic drugs like valproate. You can give one very important serious side effect. Remember, A for agranulocytosis. So clozapine can decrease WBC, especially the absolute neutrophil count. So patient on clozapine comes to us and the patient is having fever. Patient is having sore throat. There is tachycardia. So they are trying to tell you, patient on clozapine comes to us with infection. So what you are thinking of agranulocytosis. Please remember, patient can die because of this. So what we'll do, we'll check the we'll check these levels, we'll check the counts and stop it if the WBC is less than 3000 cells per millimeter cube. The absolute neutrophil count is less than 1500 per millimeter cube. In fact, this is such a serious side effect that whenever we start clozapine, for the first 6 months we monitor these levels weekly. So every week we monitor it. If everything is going fine, then for the next 6 months we do it bi-weekly. That means every 2 weeks we will check these, and after that every month we will check these levels. So this question was asked, which serious side effect of clozapine requires close blood monitoring? Answer was agranulocytosis. One more you can remember, patient comes to us on clozapine with chest pain. There is abnormal ECG, there is tachycardia. So remember, even myocarditis can occur. Again, you will stop the drug. Okay. Now one interesting FQ, that is a new question I will discuss. Okay. Now patient on clozapine, he has developed seizure. My question is, which, name one anti-epileptic drug which you will not give with clozapine. Okay. Yes. So please remember, C for contraindicated, C for clozapine, C for carbamazepine. Again, this is an integration of your pharma and psychiatry. In pharma, you will read carbamazepine can cause bone marrow suppression, isn't it? And in with clozapine also we are saying it is agranulocytosis, lethal combination if we give them together. So don't combine these drugs. Any drugs which is also causing bone marrow suppression, don't give with clozapine. So again, such newer questions may be asked, so please be very careful. I hope this is clear to everyone, right? Now, let's talk about some, this table, finding this, such questions on the adverse effects of antipsychotics they are asking in your exams. So let's talk about antipsychotics induced weight gain. Normally we discussed that weight gain will be more with second generation, less with first generation drugs. So we discussed weight gain will be more with second generation and less with first generation. So two of the important drugs, clozapine, olanzapine, can cause high risk of weight gain. In moderate, some of the other second generation drugs like risperidone we discussed. Again, EPS also, remember, one of the drugs with high EPS in second generation. Quetiapine, paliperidone. But see here, there is one first generation drug which also has a moderate risk. Remember, we discussed chlorpromazine, because of some other mechanism also can cause weight gain. So this one point remember. In the low, if you see two drugs, aripiprazole and ziprasidone. So how you can remember A to Z? So two second generation, at least remember, that is aripiprazole and ziprasidone, they may cause low risk of weight gain. So the risk of weight gain is more with chlorpromazine than the second generation drug like aripiprazole and ziprasidone. And of course, some other first generation drugs like haloperidol and other drugs can also have low risk of weight gain. So please remember this point. Also remember, ziprasidone is, again, one of the drugs which can increase the QTC interval, like we discussed with first generation drug thioridazine. Okay. So these are some important points which you can remember. Now let's solve this question. So again, in this video, what my purpose is, so that you understand when you are reading psychiatry, try to see what type of questions they are asking, so that we can prepare well. We have read everything, but you have not read these points which they are asking again and again. So then, the purpose will be defeated. So see, antipsychotic with least metabolic side effect. Tell me the answer. I'm sure now you can tell me the answer. Logically, you will think, sir, chlorpromazine is a first generation drug, but again we discussed that, no? So yes, it is ziprasidone. Very good. It is ziprasidone. Okay. One more ocular side effect with quetiapine you can remember. Again, more seen in animal studies, not much with human studies, but remember, even quetiapine, which is a second generation, cataract, remember. Okay. One ocular side effect. Two, first generation also we discussed some ocular side effects. Even with this second generation one drug you can remember. Okay. I hope this is clear. Very good. Now see this. On a very similar theme, this question was also framed. So can you appreciate? A 28-year-old woman diagnosed with schizophrenia, this was this year only, in January 2025, prescribed olanzapine. So they are, saying olanzapine has been compliant for several months. However, she discontinued the treatment. Which of the following is most likely the reason for her discontinuation? Bad taste, NMS, acute dystonia, weight gain. Of course, EPS can also occur, but here, again, it is one of the drugs with very high risk of weight gain. So here the answer is, again, many times patients say, sir, my weight is increasing, the lipid profile is getting deranged, I'm becoming hypertensive. So these metabolic side effects can occur and can be one of the reasons for discontinuation. Okay, so here the answer is yes. Very good. That is why I'm saying please be very careful when such question come. Now last point, there is one latest update, one new drug approved for schizophrenia in 2024. One of the newer drugs with a very different mechanism of action. In the etiology of schizophrenia, so here you can again compare. There is decrease in some of the neurotransmitters like acetylcholine, there is decrease in norepinephrine, even glutamate to an extent you can say. Many of these neurotransmitters are reduced, even as so many of these, even glycine, many of these neurotransmitters are reduced. So can I say if we give a cholinergic agonist, this may help in the management of schizophrenia, isn't it? So there is one drug, remember the name xanomeline. Remember the name xanomeline, M is coming in between. So what is the mechanism? Remember it is a M1 M4 muscarinic acetylcholine receptor agonist. So remember xanomeline. So please remember it's a drug. After 30-40 years there is a new drug which is not affecting dopamine, but it has a different mechanism of action. And this is given in combination with trospium. It is given in combination because patient, when we are giving muscarinic agonist, can have peripheral muscarinic agonist side effects. So we are also adding a muscarinic antagonist which is working mostly in the peripheral tissue. So remember this name xanomeline, very important. It's a new drug which is approved for schizophrenia. One more point from the name itself you can remember, L is coming in between. It is not recommended for mild liver disease. In fact, contraindicated in severe renal and hepatic impairment, but even in mild liver disease it is not recommended. So will you be able to remember this name xanomeline? Please remember a new drug xanomeline. Now see this question. A patient since 3 months believes that his daughter wants to kill him. What is the likely diagnosis? So when we're talking about schizophrenia, let's talk about some other psychotic disorders. First tell me what is the symptom here. Can you tell me what is the symptom you can see in the patient here? He believes that the daughter wants to harm him. Okay, yes. So here patient is having only delusion. So can I make a diagnosis of schizophrenia based on only delusion? No, na? Yes, very good. So if the patient is having only delusions, then the diagnosis is delusional disorder. Very good. Yes, very good. All of you are correct. Yes. So the right answer here is it is delusional disorder. Very good. Now let's talk about some points about mood disorder. So we have covered two very important topics today. Two very important topics we have covered, right? Now before coming to substance use disorder, I want to briefly will discuss mood disorders. So I'll talk about here symptoms today. Okay, so when you're preparing again, management also antidepressant, mood stabilizer, but here let's try to identify these diagnoses. So let's talk about mood disorders. Okay, then we'll come to the last and very important topic, which is substance. Substance use is something which I want to definitely discuss today. Okay, now a patient is diagnosed with MDD. MDD is major depressive disorder. What is the key feature of depression? Can you tell me? Options are decreased interest, low appetite, suicidal thoughts, or low mood. Tell me what is the answer. Tell me what is the answer. Very good. So now let's talk about the symptoms. Now depression, to make a diagnosis of depression, the duration is 2 weeks and the mnemonic is very simple. Remember SIGE CAPS. Very simple. From the from the mnemonic you will remember the symptoms of depression. So the minimum duration of symptom is depression is 2 weeks. So S is sad. So again, mood disorder may always remember, mood disorder or affective disorder means there is abnormality of mood. In depressive disorders the mood is always low. So it is always on the lower pole. While we'll talk about bipolar disorder, sometimes the patient's mood is on the above pole, patient is having mania, hypomania, and sometimes it is on the lower pole. So it can be above and below. So here can you appreciate why we call it bipolar? Because symptoms are occurring on both the poles. While in depressive disorders, patient is having always symptoms on the lower pole. Okay, so please see this. S for sad mood, interest. What happens to interest? Interest is reduced. That is known as anhedonia. Anhedonia. Then G, remember SIGE. G for guilt. Patient is having feelings of guilt, worthlessness. I am good for nothing. Such feelings patient has. Energy levels are low, patient is fatigued very easily. So this is SIGE. Coming to CAPS, C for concentration, patient's concentration reduces. So many times patient comes with complaints, sir, I am forgetting things. I have forgotten where I have kept documents, my keys. So this is sometimes referred to as, remember, pseudo dementia. Again, this is sometimes asked, pseudo dementia is seen in which condition? It is seen in depression. So that means we don't have to separately treat pseudo dementia. You treat depression, pseudo dementia will also improve. A for, remember, appetite. So appetite usually decreases, patient's weight also reduces. Patient says, sir, my weight is decreasing, sir, मुझे भूख कम लगती है. But sometimes patient may also report opposite, sir, my appetite is increasing and even my weight has increased. Psychomotor activity, again, it can decrease usually. Patient is talking very slowly, walking very slowly, but sometimes it may also increase. 2S, remember, one is sleep. Sleep can again decrease, there can be insomnia and there can be hypersomnia. S for, remember, suicidal ideations or suicidal attempt, that can also be seen. So these are the symptoms of depression. Now in the diagnosis, remember, we say that 5 or more symptoms should be present and duration is for at least 2 weeks. But there is a catch. The catch is at least one symptom should be from first two. So can I say that these 2 symptoms are very crucial, very key? So please see this. In the question, both decrease interest and low mood both are given. But if you have to choose one, I told you mood disorder means abnormality of mood. Then I will go with low mood. If low mood is not given, then you can also choose decrease interest. So please always try to appreciate this. Always try to understand this so that it becomes very easy. You know the diagnostic criteria, they will ask questions, newer questions. So this is how they may frame newer questions. So please be very careful when such question comes. Now, which of the following is not a component of Beck cognitive theory of depression? Now again, there are so many theories of depression. This was asked recently in NICT. So when you read, also focus on some important points in the etiology. So you know, there is a etiology, there is one theory known as the cognitive theory of depression. So it was given by Aaron Beck. Aaron Beck said that patients who develop depression, they develop cognitive distortions. What are these cognitive distortions? They are automatic negative thoughts. So patient says, sir, automatically negative thoughts are coming in my mind. So they may be dysfunctional beliefs which the patient has, and because of that patient may develop these automatic negative thoughts. So which is not in a component, the answer is C. So please remember cognitive theory. He also gave a cognitive triad, very good. All of you are mentioning this triad. So let me just tell you the triad, cognitive triad of depression. That negative views about self, that is worthlessness, negative views about environment, that is helplessness, negative views about the future, hopelessness. Yes, that is cognitive triad. And that which we discussed was cognitive theory of depression. That was again given by Aaron Beck. I hope this is clear to everyone. Very important point. Now, let me talk about some, again, when we talk about mood disorders, let me also talk about bipolar disorder. So we talked about depression. We discussed depression. In depression, patient is having symptoms always on the lower pole. While in bipolar disorder, what is happening? Sometimes the symptoms are on the lower pole and sometimes patient may have symptoms on the upper pole. So that means patient may have mania or hypomania. So again, very important, whenever they give questions, when you have to make a diagnosis. So they may tell you currently patient is having some episode and they may tell you there is a past history. So patient, let us say currently, so let me just tell you this. Suppose currently today patient has come to me with depression. I am thinking of depressive disorder, MDD, major depressive disorder, but they tell you in the past patient had an episode of mania or hypomania. So now can you tell me what will be the diagnosis? The diagnosis has changed now. It is actually bipolar disorder. So depressive disorder diagnosis we already know. Let's understand how to make a diagnosis of mania or hypomania. Let's talk about first symptoms of mania. Can anybody tell me what are the symptoms of mania? Can anybody tell me how do we make a diagnosis of mania? What are the symptoms? Very good. So the duration is 1 week and the mnemonic you can remember, me dig fast. It's a mood disorder, so always remember first symptom will always be mood. Very good. M, remember mood. So I have added me. In the books you will see dig fast, I have added me so that all the symptoms we cover. M is mood. The mood is very happy. So patient is very happy, he is laughing, he is cracking joke without any reason. So mood is very high. Okay. Sometimes remember it can also be irritable. And what is E, energy levels or the activity, they are significantly increased. So patient is very full of energy. The mood is high, the energy is high. So this is me. Then let's discuss dig. D is distractible. Patient is getting distractible very easily. I am talking to the patient, there is some noise, he is distracted there. There is some noise, he is distracted there. So very easily distracted. I is impulsivity. Patient may do things without considering the consequences. बिना सोचे समझे patient may do things. For example, patient is spending a lot. Patient is over religious. Patient is over familiarization is there. You know, he is going and hugging the strangers. Oh, he's my brother. Even sexual activities may increase. So there is impulsivity. Remember G for grandiosity. I am not saying here delusion of grandiosity. Grandiosity here means inflated self-esteem. So patient may have a inflated self-esteem. Then next is fast. That is flight of ideas we discussed. A, again activity increase. Sleep, remember there is decrease need for sleep. There is a decrease need for sleep. So patient says sir, sleep is a waste of time. Who requires sleep? Patient is sleeping just 1 or 2 hours and he is still full of energy. And talkative, T for talkative. Very good. Okay, very good. Yes. So is it clear to everyone? So this is yes. So please remember, hypomania it is 4 days. Don't worry. For hypomania it will be 4 days. For mania it is 7 days. Okay, 1 week. Now to make the diagnosis we say that both 1 and 2 should be present. Both of these symptoms should be present plus 3 or more of the remaining symptoms. Okay. So total here also there are 5 symptoms. But here again 1 and 2. Again if they ask you what is the key feature, then we will say again it is mood. That is mood is elevated, sometimes it may be irritable. So I hope it is clear. See this. So this was the question which they asked. A 24-year-old male with a previous history of psychiatric disorder has become very aggressive with his neighbors. He is cheerful, he is speaking rapidly, so the mood is cheerful, speaking very rapidly, he is aggressive, there is aggression, sleeping very little. Also has shown hyperactive, the activity levels have increased after discontinuing his prescribed medication. What is the diagnosis? Can you tell me now? Is it depression? Of course it is not depression. Is it schizophrenia? No, they are not mentioning symptoms. Substance, they have not mentioned any, substance patient is taking. So you have ruled out that also. Yes, the answer is it is manic episode, bipolar disorder. Very good. Now also let's try to understand how to differentiate mania from hypomania. Now can you appreciate here it is hypo. So the name is telling you that the symptoms are less severe than mania. So even duration you can remember, the minimum duration is 4 days. For symptoms for 4 days, then we call it as hypomania. So symptoms are similar to mania, but although they are not severe, so what they will tell you that there is not significant impairment in functioning. Like in mania, the functioning means social functioning, his occupational functioning, his personal functioning will be affected. So in mania, patient may not be able to work properly in the office, his social life will be affected. But here, since the symptoms are not very severe, somewhere in the question they will tell you that there is no significant impairment in functioning. This is suggesting that it is hypomania. Also remember few more points to help us differentiate mania from hypomania. There will be no psychotic symptoms. Sometimes patient with mania may develop delusions, hallucinations, while hypomania will not develop. So if the patient has developed psychotic symptoms, then I will call it as mania. There is no need for hospitalization in hypomania. Somewhere in the question they tell you that patient is hospitalized, that means the symptoms are now increased. Now I will call it as mania. Also usually we discussed that flight of ideas is more seen in mania. So that also is not seen in hypomania. So in fact this question was asked in NEET PG. A patient has elevated mood, excessive energy, flight of ideas. Mania, hypomania both were in the option. The answer was mania. So please remember this. I hope this is clear. Okay. Now not bit of significant impairment I am saying. I am not saying there is no impairment. There is some impairment is there, but not as high as we see in mania. So yes, some degree of impairment is there. You are correct. When we talk about disorder we say this. So remember, the impairment is not very severe. So I told you, based on the functional impairment, sometimes we can distinguish between the disorders. So I hope this is clear to everyone. So again, very important points. One more point you can remember, what is rapid cycling. This is a topic which they have been asking again and again. Last year in NICT and also in FMGE, you will see such question. That is, I am saying, they are repeating the topics. They are framing new questions, but they are repeating the topic. What is rapid cycling? Rapid means fast, cycling means up and down. So if the symptoms, can you appreciate in this image, patient had at least 4 episodes of depression, mania, hypomania in 1 year. Isn't it very good? Yes, all of you are correct. It is 4 or more episodes of depression, hypomania, mania in 1 year. That is known as rapid cycling. So I always discuss, in the treatment, one of the drugs which is preferred is valproate. This was asked in this year FMG exam. Also remember, now studies are showing even lamotrigine. Lamotrigine is also, a mood stabilizer which has shown results in rapid cycling. Rapid cycling is more common in males or females? Tell me. So again, it is more common in males or females? Remember this, it is more common in females than male. This was asked in NICT. Okay, remember, this point was asked in a different way. They had asked which is false statement, more common in males. This is the false statement. It is more common in females. Okay. I hope this is clear to everyone. Now let's talk about one of the very important topics, that is substance. So now let's discuss substance. Substance is a topic again and again you are getting questions. There is nearly no paper, in which they are not asking questions on substance. So let's come to substance. This is again a very important topic. Now let's talk about first alcohol. Now what is alcohol chemically? In the beverage alcohol, remember it is ethanol, C2H5OH. Also remember, chemically, if I ask you, alcohol is a CNS depressant or it is a CNS stimulant? Can you tell me, is it a depressant or is it a stimulant? So we have come to the last topic. Yes, so it is a stimulant or a depressant. Remember, it is a CNS depressant, very important. Okay. Now, so a patient is taking a depressant every day. Let us say he is taking 1 full bottle of alcohol. How much is 1 bottle? 750 ml of alcohol every day. If you know, it's okay. If you don't know, even better. Don't worry. So he is taking, let us say, 1 bottle of whiskey, 750 ml every day, and suddenly he stops. So what will happen? We are giving a depressant and suddenly the depressant is stopped. So brain may go in a hyper excited state. So the withdrawal symptoms you will be able to appreciate. These are telling us the brain is in a hyper excited state. Okay, very good. So patient has stopped suddenly or decreased the amount suddenly. Within next 6 to 8 hours, patient comes to us and says, sir, look what is happening. What is this? What has started? Patient has started with tremors. This question was asked, which is the earliest or the most common withdrawal symptom? Tremors. Along with this, other symptoms like GI symptoms, autonomic symptoms like hypertension may also be seen. Now suppose patient continues to be in the withdrawal state. So abhi 8 to 12 hours have passed and still the patient is in the withdrawal state. Now you see the patient is talking to someone when no one is around. So now what has started? Alcoholic hallucinosis has started. So patient may develop hallucinations such as auditory hallucination, even visual, even tactile hallucinations can occur. Okay. Now suppose this withdrawal state continues in the next, now 12 to 24 hours have passed by. So now what has developed? Patient is having abnormal jerky movements, uprolling of eyes, clenching of teeth, okay, urinary fecal incontinence. What has now occurred? Seizures. So remember, withdrawal seizures can also occur. Can you appreciate? They are suggesting that brain is in a hyperexcited state. These are generalized tonic-clonic seizures, also known as rump fits. And up to 72 hours, that is peak in 48 to 72 hours, patient comes to you and patient is in the hospital, but patient says, sir, I am at my home. Now tell me what is the diagnosis. From whatever we have discussed right now, tell me what diagnosis you have made and tell me why. I want to, see both the points. You are saying it is delirium tremens, very good. You are very correct, it is delirium tremens. Now tell me why you are saying delirium tremens. Very good. This is very important. बेटा दैट इज वाई एम सेइंग ना, डिप्रेसेंट है तो जब वो ले रहा है तो इट इज डिप्रेसेंट ना. अभी तो विड्रॉल का मतलब अभी अल्कोहल, वी आर टॉकिंग अबाउट अल्कोहल विड्रॉल सिम्टम्स. विड्रॉल सिम्टम्स है ना, मतलब ही हैज स्टॉप टेकिंग, सो नाउ दैट डिप्रेसेंट इज गॉन, सो ब्रेन इज इन एन हाइपर एक्साइटेड स्टेट. हाँ, because we are saying it is delirium tremens. Remember I told you, delirium mein the consciousness, there is impairment of consciousness. Remember this point? Impairment of consciousness. I told you 4 points. We discussed patient is having clouding of consciousness, altered sensorium, disorientation or confusion. Nowadays they tell you, they give a word confusion. Again, that is suggesting patient is having impairment of consciousness. Here I told you that patient is in the hospital but he is saying I am at my home. So he is disoriented. So that means it is delirium tremens. Delirium tremens mein which hallucination is more common? Remember, visual hallucination is more common. Is it clear? Now again I just want you to tell me, how will you differentiate alcoholic hallucinosis from delirium tremens? Just tell me this. Delirium tremens, also remember, it's a medical emergency. Patient can die. Okay. Tell me, how will you differentiate alcoholic hallucinosis from delirium tremens? I am asking this because they are asking again and again. Please be very careful. The key point is in delirium, it's a delirium. We discussed that even alcohol withdrawal can cause delirium. Impairment of consciousness. Hallucination is not the differentiating factor. Remember, impairment of consciousness will help us differentiate. Very important. I hope this is clear to everyone. Right, now see this question. Again this question was asked. A 45-year-old man with chronic alcohol intake presents to the hospital with last intake 48 hours back. Now he is complaining of seeing snakes crawling on the bed and is not able to recognize his family members. So he is having visual hallucinations. He is having visual hallucination and they have given a history of withdrawal of alcohol. Can you tell me what is the diagnosis? Very good. Yes. Yes, Som Shubhra, very good. Consciousness is intact in alcoholic hallucinosis. Very good. It is not schizophrenia. It does not appear to be alcohol-induced psychosis. It is more patient is in a withdrawal state. Right now patient is in withdrawal state, isn't it? It is, why not it is not alcoholic hallucinosis? Because patient has also developed, very good. Very good. Patient has also developed, he is not able to recognize the family member. Disorientation has also started. So now here it is delirium tremens. Can you tell me? Very good. Now see this question again. Patient stopped alcohol 3 days back and presented with irritability, disorientation, paranoid delusion, visual hallucination, altered sensorium. Again, that is why I am showing you these questions, because they are asking again and again. Those who will be giving the exam in the mid-year, any exam, please don't mark these questions incorrectly. They are asking again and again these questions. Again, the answer here is, they are telling withdrawal state mein patient has come. So we are not talking about Wernicke's or Korsakoff. We are talking of withdrawal symptoms. Again, it is delirium tremens. Patient has developed altered sensorium, disorientation. Very good. Very good. See this again. After 72 hours of cessation of alcohol, which of the following is seen usually? Usually we discuss tremors, alcoholic hallucinosis, seizures may occur earlier. 72 hours, again if you have to choose one, delirium. Of course others can also occur, but you have to choose one, delirium tremens. Of course delirium tremens can also occur on day 1. So don't make a diagnosis based on the duration, make a diagnosis based on the symptom. There is impairment of consciousness. I hope this is clear. And how will you treat a patient with alcohol withdrawal? Let's talk about the management now. Let's talk about the treatment. So let's discuss, this is again a very important slide. In the treatment, one phase is detoxification, another is maintenance. Now patient has come to us with in the withdrawal state. Detoxification means we are managing the withdrawal. Okay. Okay. Right, great. So tell me, in the detoxification, what will be the drug of choice? Now again just understand the concept. Patient was taking alcohol, which is a CNS depressant. Suddenly that depressant has gone. So the brain is in a hyper-excited state. So what drug can you give to manage these excited symptoms? Give another depressant. So can you appreciate now? Yes, very good. So benzodiazepines are the drug of choice. Very good. So benzodiazepines such as lorazepam, diazepam, oxazepam, chlordiazepoxide. In fact, temazepam is also there, but I'll discuss why I'm discussing. I'll give you one mnemonic. Now, so one simple question is, benzodiazepines are the drug of choice. Many a times in the question you will see that they will tell you that the LFTs are deranged or patient is having hepatomegaly. So somewhere in the question they are trying to tell you patient has a liver disease. It can occur, patient is taking alcohol for so long. So now they will ask you which drug is used. So remember, the trick to remember liver okay treatment. So you can remember it with like this: liver okay treatment. Remember lorazepam, oxazepam, even temazepam. These are relatively safe in liver disease. So then if they ask a question of withdrawal and they give somewhere in the question that patient has icterus, patient has liver cirrhosis, hepatomegaly, then think of these drugs. Now what we do, we start with benzodiazepines at high dose depending on the withdrawal symptom, then we taper and stop. By 7 to 14 days we stop these drugs. Can you tell me any other drug would you like to? Very good. Liver okay treatment, very good. Can you tell me any other drug you would like to add in these patients? Let's complete the treatment. So sometimes one option is lorazepam and one option may be lorazepam plus. What we will add? Thiamine also can be added, because many times thiamine may be deficient in these patients. So this is about the detoxification. So we have discussed drugs in the detoxification withdrawal state. Now let's talk about management. So we have managed the withdrawal symptoms. Now the patient comes, says, thank you sir, thank you ma'am, can I go home? What will you say, yes or no? Patient has come to us, very good, yes, vitamin B1. So patient has come to us, say, thank you sir, ma'am, can I go home? What will say, yes, you can go home. Yes, patient has spent so many time in the hospital, you can, let him go home, but now you want him to be in the maintenance phase. It's not that he go back home and again start consuming. So two drugs you can remember, one is disulfiram, which is a aversive agent. Disulfiram is a aversive agent. It is a aldehyde dehydrogenase inhibitor. When a patient is taking disulfiram and he consumes alcohol, he may develop unpleasant symptoms. So that is one drug. Then more commonly we may use anti-craving agents. So remember two important anti-craving agents which are approved by the FDA. One is acamprosate, another is naltrexone. Can you tell me what is the mechanism of action of acamprosate? What is the mechanism of action of acamprosate? Remember acamprosate same as memantine. That is, it is a NMDA antagonist, and I am sure all of us know opioid, these are mu antagonist. I hope this is clear. So these are two important anti-craving agents which may be used. Very good. Is it clear to everyone? Now let's talk about this also. This is again, please highlight this in your notes, very important. I'll also discuss newer questions. One of the new questions which I've been discussing, we discussed in LRR also, and it came as a new question in last NEET PG exam. One more point we'll discuss. Okay, so let's talk about two important alcohol-induced neurocognitive disorders. One is Wernicke's encephalopathy and another is Korsakoff. So these are neurocognitive disorders. Again, the onset of Wernicke's encephalopathy, remember, is sudden. So suddenly, within few hours or few days, the symptoms have started. And how will you remember the symptoms? Can you tell me what is the mnemonic? What is this mnemonic? GOA. So what is G? G is global confusion. Patient is confused. O is ophthalmoplegia. Patient is having ocular signs or symptoms. Patient comes like this, and my eyes are deviated to one side. So usually we see 6th cranial nerve may be affected more than 3rd cranial nerve. Patient is trying to walk and he falls. He is trying to walk, he falls. This is ataxia. Okay. Again, please remember, confusion is also seen in delirium tremens, but there they will tell you patient is in a withdrawal state. He is having other symptoms of alcohol withdrawal. Here, the patient is having other symptoms along with confusion. So remember the mnemonic GOA. GOA is very famous for Fanny. So remember GOA. Tell me what is the cause. Can anybody tell me what is the cause of Wernicke's encephalopathy, and even same goes with Korsakoff also. The cause is because of deficiency of vitamin B1, that is thiamine deficiency, that is causing both these syndrome. Okay, so please remember, very important, the deficiency of thiamine. Okay, very good. Vitamin B1. So what is Korsakoff? Korsakoff, remember, it is a chronic sequelae. Symptoms develop, take a longer time. And here important symptom is, one is amnesia. So one of the symptoms is amnesia. So there is problems in memory. In fact, it is one of the amnestic disorder. Korsakoff is a amnestic disorder. Here there is only, main symptom is amnesia. Anterograde is more than retrograde. Both may occur, but anterograde more than retrograde. Okay. Confabulation. What is confabulation? Filling of the memory gap. Very good. Filling of the memory gap with false stories. Very good. False stories. Very good. Again, the cause is deficiency. The cause is deficiency of vitamin B1, thiamine. Okay, I hope this is clear. Again, coming to the treatment will be thiamine. So for both thiamine, usually we see that Wernicke's is usually the symptoms are reversible, while some symptoms with Korsakoff may remain. So you can say they are partially reversible or irreversible. Okay, irreversible. Now, two important points which I want you to remember. First of all, whenever a patient with alcohol related disorder comes to us, it's a good practice to always, when we are giving patient glucose solution, it's always good to give thiamine either before or we add thiamine in the glucose solution, because thiamine is required for metabolism of glucose. There are various enzymes you will read in biochemistry, thiamine pyrophosphate, TPP. Again, thiamine acts as a cofactor in some of the enzymes like alpha ketoglutarate dehydrogenase, okay, and so many other, okay, even trans ketolase, even pyruvate dehydrogenase. These are the enzymes which require thiamine. Now if thiamine is deficient, so glucose is not metabolized. So it's always a good practice to give thiamine before. When we are giving glucose, give thiamine before, or you add thiamine in the glucose solution. So this point in fact was asked. I will discuss that question. Now second question which I am asking is, patient comes to us with these symptoms, Goa. Patient is coming with these symptoms of Goa. So what you are suspecting Wernicke's encephalopathy. But in the question they tell you that patient does not show response to thiamine, no response to thiamine. So that means it is looking like Wernicke's, but it is not Wernicke's. So remember one more condition, that is pellaggric encephalopathy. So this may come as a new question. Pellaggric encephalopathy may also appear like Wernicke's. So here now the treatment will be, what will you will give? You will give niacin. I hope this is clear. Again, please put a hashtag new point, please remember. So this is another question may come. So remember, you will give what? Niacin. Okay. Now see this question which was asked in the NEET PG exam. That is why I am saying they are repeating the topic, but they are framing newer questions. A person chronically consumes alcohol, indulged in binge drinking 10 days back and was brought to the emergency unconscious. So he's brought unconscious, they did non-contrast CT, it was normal, so it does not seem to be because of any head injury or other causes. When they checked, his blood glucose was 45 milligram per deciliter, so he's having hypoglycemia. So patient with chronic use of alcohol, and now you're planning to give him glucose, or let us say dextrose. So what is the treatment? Can you tell me what will be the answer here? What will be the answer here? Anybody? Yes, very good. So you will give thiamine first, followed by dextrose. Very good. So that is why I'm saying, please appreciate the clinical scenario and try to see what answer it could be. Very good. I'm very happy. Yes. Okay. Correct. Now, see this another question was asked. Again, see so many repeated questions on all the exam. You will see questions from these topics. Korsakoff syndrome, you have to, and which symptom can be seen? Amnesia we discussed. Confabulation, it can be seen. Peripheral neuropathy, patient is taking alcohol chronically. Ophthalmoplegia usually is associated with Wernicke's. Okay, so the answer is 1, 2, 4. So that means option A is correct. So again, please see this. Now, let's talk about this question. This is also one of the topics they are again and again asking. So next, let's talk about opioid overdose. They're telling you that the patient is having a suspected opioid overdose, comes to the emergency room, is having respiratory distress, bradycardia and hypotension. What is the management? What is the management of opioid intoxication overdose? Can anybody tell me? Yes, we will give, yes, it is naloxone. Very good. The correct answer is option B. It is naloxone. So let's talk about opioid intoxication. But there is a clinical triad of respiratory depression. Please remember, pinpoint pupil or meiosis is seen in opioid intoxication. Again and again, this point somewhere or the other, you'll see even in forensic question, patient has come with some intoxication, the pupils are constricted. Again, they are giving opioid in the option. Coma can occur, and the drug of choice is, we will give IV naloxone. It is a opioid antagonist, it is short acting. That is the treatment of choice for managing opioid intoxication. So please remember this, a very important slide. Okay, this point also they've asked again and again. Okay, let me show you some questions so that we can see this. In fact, this is again, a mother reported that her daughter is ingested substance in unknown dose. The girl presents with hypertension, tachycardia, Here they are mentioning it to be, remember here it is mydriasis and hyperthermia. So can I say again, heroin, morphine, these are opioids, isn't it? So please remember, just by knowing, few of the points, you can see here the patient is having pupillary dilation. So what is this substance? Can anybody tell me what is this substance we are dealing with? Yes, in withdrawal it is, in the withdrawal opioid withdrawal it is mydriasis. Yes, here it is intoxication na. So what will be the answer here? Can anybody tell me this substance which is cocaine? Again they are giving this patient is having meiosis or mydriasis. Meiosis, remember, one of the important substances opioid. So we have ruled out heroin, morphine, these are opioids. They are causing meiosis. Here it is yes. So let's talk about one more. Let's talk about this again, a very important small topic but very important, cocaine. So there are various stimulants such as cocaine, amphetamine. One important stimulant, let's talk about cocaine. It is derived from Erythroxylum coca, from the leaves of the plant Erythroxylum coca. Now it's a stimulant as the name suggests, so it will cause what? Hypertension, tachycardia, tachypnea, cardiac arrhythmia, seizures, and remember even it can cause mydriasis. In fact, I'll give you one trick. Remember TCA. So even in tricyclic antidepressant toxicity, you will read even TCA toxicity can cause mydriasis. So one, remember T for TCA, C for cocaine, A for amphetamine. Okay, so these three important drugs you can remember, they can cause mydriasis. Okay, so yes, it can cause mydriasis. Now another important point, can anybody tell me, we discussed about cocaine, what we discussed in the basics. Patient is having some sensations, some insects are crawling over or under the skin. What is this? This is tactile hallucinations that can also occur with cocaine. What are speedballs? What are speedballs? When someone combines, use cocaine along with opioids like heroin, that is known as speedball. So please remember this. Okay, I'll repeat that question again. It's a stimulant now, it is increasing the sympathetic activity. So again that question I'll repeat. A patient comes with tachycardia, tachypnea and scratch marks. So can you appreciate tachycardia, tachypnea? This is suggesting it's a stimulant, and scratch marks is telling me it may be because of tactile hallucination caused by cocaine. Now a patient, many times you will see patients not take it intranasally, and it is a stimulant, it is causing vasoconstriction. Long term use, when you see the nose, what findings we may see? There may be bleeding, and ultimately what may happen to the nasal septum. So please remember, there may be nasal septal perforation, and in the tongue, when we see, there may be jet black pigmentation. Very good. Yes, yes, I'm very happy. Yes, all of you are marking correctly. Yes, so these can be seen. Very good. Now see this another question. Which of the following is not seen in patient who use heavy dose of cocaine? Again, they are asking, somewhere or the other such questions. Tell me what will be the answer. Tell me what will be the answer here. Yes, so usually bradycardia may be less common. Okay. Yes, because it's a stimulant. So please see this. When you know the concept, even if a question, newer question like this may come, you will be able to approach that question. Very good. Okay. Now let's talk about the last substance. Let's talk about one more substance today, and then we'll end. And then we'll take up one more question which was asked in the recent INICET exam: tobacco or nicotine. Okay. Tobacco, the psychoactive agent in tobacco is nicotine. Okay. So please remember, in fact, if they ask you most common substance in India, remember it will be tobacco followed by alcohol. In the world, if they ask you, it is alcohol followed by tobacco. If they ask you most common illicit substance, tell me, if they ask you most common illicit means illegal. Okay, tobacco, alcohol, they may be legally available. But if I ask you most common illicit substance, India and world, then what will be the answer? Can anybody tell me most common illicit substance in India as well as the world? What will be the answer here? It will be, starts with C. Can anybody tell me? It is cannabis. Cannabis. Now also remember, very good, it is cannabis. Remember, it is cannabis. Also remember, I told you most common in India, I told you tobacco followed by alcohol. In world, it is, alcohol followed by tobacco. But if they give caffeine in the option now, caffeine is also considered as a substance use disorder, then it becomes the most common. In the earlier questions, PYQs, you will see tobacco being the answer. But remember, if caffeine now is given in the option, ICD 11 says it is now the most widely used psychoactive substance. So it will be the better answer if caffeine is given in the option. Okay. Now coming to the treatment, So we can use nicotine replacement therapy. So patient is taking nicotine in tobacco, and along with this he is having so many other impurities. Many of them are also carcinogens. So what we do, we replace it by nicotine. So nicotine replacement therapy in the form of gums, lozenges, patches, even inhalers, other forms are also available. So this is one method. We have two important anti-craving agents for nicotine. One is Wernicke and another is bupropion. Now again, two anti-craving agents, FDA approved anti-craving agent for alcohol we discussed, two you can remember for nicotine. What is the mechanism of action of Wernicke? Remember, it's a partial agonist. Yes, tobacco is a CNS stimulant. Yes, tobacco is a stimulant. Partial agonist at alpha 4 beta 2 N-acetylcholine receptors. So please remember alpha 4, पहले आ रहा है 4, फिर beta 2. Now one important side effect you can remember, it can increase suicidal thoughts. Recent studies have, refuted this finding, but still it is, carried as a warning with Wernicke. What is bupropion? Let's discuss bupropion. Bupropion, again an interesting drug. It is an antidepressant. It is a NDRI, that is norepinephrine dopamine reuptake inhibitor. So this question was asked, antidepressant used for smoking cessation, bupropion. Okay, now let's list some important uses of bupropion. It is an antidepressant. It is used for smoking cessation. It is used for smoking cessation, and also it can be used in ADHD. It's a child psychiatric disorder, ADHD, as a non-stimulant. Suppose a 24-year-old male comes to us, he is having depression, smokes cigarette and has ADHD. So again, there also you can use bupropion. One more point, remember, bupropion is contraindicated in bulimia nervosa and anorexia nervosa. These are eating disorders, because there is a side effect with bupropion. It can cause seizures. So in conditions which can increase the risk of seizure, in bulimia nervosa, patient is having binge eating and is using purging like self-induced vomiting. So vomiting can cause electrolyte imbalance. It can cause increased risk of seizure. In anorexia nervosa, patient is not eating, again increased risk of seizure. In those situations, we will not give bupropion. Okay. Now, last question from this, if they ask you which is the most efficacious or effective drug out of these, then what will you answer? Okay, what will you answer? We'll come back, again you can see the videos, again you can see the videos for other topics. Today, since we are, in the initial phases of treatment, we are discussing some important topics, and of course in the end also we'll, discuss with the revision also. Now tell me, if they ask you most effective, then the answer is Wernicke. Wernicke is the most effective drug. This question was also asked. A lady wants to quit smoking, both Wernicke and bupropion were given in the option, then it is Wernicke. I hope this is clear. Let's see this question. Very good. Now again, INICET recently, when they asked question, only one question they asked this time, and that question again, can you appreciate, they had asked from substance. So the answer, tell me, for delirium, what will you choose? What is the treatment for delirium? What is the treatment for delirium? Can you tell me? What out of these drugs? It is alcohol withdrawal, oxazepam. The benzodiazepine you will choose. For alcohol dependence, now they are asking about maintenance, there is acamprosate. For smoking cessation, then the drug is Wernicke, and for opioid overdose or poisoning, that is naloxone. So what will be the answer? 1, A2. So we have two options, A2, B4. Yes, so this is C3 and D1. So this is the correct answer. Yes, so see this, again and again such topics have been repeated. Okay, so these were some important topics we have discussed. Again, there are some months left, and again, few messages I want to convey. Please remember, there may be times, when there may be certain uncertainties, there may be challenges. Nowadays we are seeing so many, uncertainties about, so many things. So remember, it's not the strongest nor the intelligent of the species that survive, but the one that is most adaptable to change. So please remember, any change will occur in the pattern, anything, it is for everyone. So again, we have to focus on things which are under our control. Okay, and again a very important slide, again recently so many students cleared the recent exams, and I loved listening to their success stories, and again would want to eagerly listen to your success story as well. So take one day at a time. I always say, don't think too much, focus on things which are under your control. Wake up every day, be with the hope I'll do well. At night when you're sleeping, however the day went, there will be, every day will not be a very good day. Some days will be there when the preparation may not be gone according to your expectation. So it's okay. Sleep with a gratitude that however it went. Now next day I'll again come back and do the best I can. That's it. And again, please remember, when you're reading theory, also solve MCQs. Please give GTs, solve MCQs, and try to revise whatever you have read every day in the night. Just for half an hour, try to revise whatever you read in every day, and you will see things will start consolidating in your mind. Okay, so with this, I think we'll stop for today. My two simple mantras, as I always say: keep smiling, keep a smile. Smiling will not change the consequences, but it will change the way you are handling the situations, and keep moving forward. Take one day at a time. So again, thank you very much. May God bless you all. Thank you.